Great. So my name's Chike. I'm from the research team in Leicester. I work as a consultant there as well. So I'm going to chair this session. And as Karen says, we've got some real true experts in the field. So very lucky to have these speakers. I'm going to start by introducing Professor Barratt. Jonathan is a consultant nephrologist, leads laboratory and clinical research in Leicester, and will give us a talk on IgA Nephropathy, a beginner's guide.
So welcome everyone. As Karen says, please feel free to shout out and interrupt at any time if you've got a question. This is purely and simply an event so that you guys get to learn more about the disease. And I know there are people here as well with HSP or IgA vasculitis. And so I'm going to try and touch on how that intertwines with IgA nephropathy in this talk as well. So I want to take you back to 1968. So I'm looking around the room, and I'm not going to say who I think was probably around in 1968. But there was some devastating fashion. Richard Nixon was just elected president of the US. There was the Mexico Olympics. Martin Luther King was assassinated. First manned flight around the moon. Planet of the Apes, 2001. We're on at the cinema. And just across the channel, this gentleman, Jean Berger, first described IgA nephropathy. And he was able to describe it because someone developed a way of looking at kidney biopsies and being able to stain the kidney for IgA in the very fine filters in the kidneys. So IgA this year is celebrating its 50th anniversary. But clearly IgA nephropathy didn't just suddenly appear in 1968. So if we look back, there have been studies performed on people that lived in the 18th century that show that they too had IgA nephropathy. Didn't know it at the time, but because they were important people, their organs were preserved, and people have gone back and looked at them. So I know one person in the room knows who this guy is. Does anyone else? So this is the father of the US Navy, and his claim to fame, I learnt, was that he famously invaded the UK on behalf of America. It didn't work, but when people looked at his kidneys, he was shown to have IgA nephropathy, along with the Crown Prince of here, Joseph Habsburg. So we know it's been around since at least the 18th century. And since its first description 50 years ago, it's now regarded as the commonest pattern of glomerulonephritis in the world. But it is rare in the UK. IgA vasculitis is even rarer. And so one of the things that's come up from these days is patients often sit in clinic with another 30 people going to see the consultant, and there won't be another IgA nephropathy patient in the room. You'll never have met someone with IgA nephropathy or IgA vasculitis before. The likelihood is your GP only probably has one patient with IgA vasculitis out of the 10,000 on their list. So that means that it's often very challenging to get information because you have a rare disease, and I'll come back to that for the initiatives that are happening in the UK to try and look at these diseases. So let's start with the kidneys. So the kidneys are here, sitting in the small of your back. In IgA nephropathy and IgA vasculitis, both kidneys are affected equally. One of the commonest questions we have is it just the right or the left kidney? Both kidneys are equally affected. So what do the kidneys do? Well, the kidneys control your salt and water balance. So any of you that go to see the nephrologist regularly will know we are obsessed by whether your ankles are swelling. And that's because if your kidneys aren't working, you retain salt and water. And the first place we see that is on your ankles. They're involved in getting rid of all the products that the body doesn't need anymore. And when the kidney function gets very low, these waste products can start causing symptoms. They can start making you feel sick, not wanting to eat, itchy. And that's that's the sign that these waste products are building up. They also generate hormones, so they're very important in controlling vitamin D. And vitamin D is very important in maintaining the health of your bones. They also produce a drug called EPO. So anyone who follows the Tour de France will realise there's lots of cyclists love taking EPO, allegedly. This has been streamed, isn't it? So I've got to be careful. But this stops you from becoming anemic. So for some of you who may have developed dialysis-dependent renal failure, you may well be given EPO as an injection to try and get your blood count back to normal. And Finally, and perhaps one of the most important things, is the kidneys control your blood pressure. And you'll all have been to see a kidney doctor, and we are obsessed with your blood pressure because kidney disease causes high blood pressure, and high blood pressure damages kidneys. And you get into a vicious cycle, if you're not careful, of one causing the other, making the other worse, which is why we are very, very concerned about people who have high blood pressure. We want to make sure we treat that as well as possible. And so how do the kidneys do this? Well, the kidneys are processing a litre of blood every minute. So they are cleaning a litre of blood every minute. That means 180 litres are filtered a day. You have 5 litres, roughly, circulating blood volume, which means your blood is entirely cleaned at least 60 times a day. Now, clearly, that isn't all produced as urine, so the kidneys actually reabsorb the vast majority of the fluid that they filter, or else you'd turn out like a crisp in about an hour because you've lost all your fluid. So the kidneys are working continually, both of them simultaneously, to clean your blood of any toxins or any excess salt or water that you have in your body. And to do this, the kidneys have a very, very precise filtering mechanism. So each of the kidneys contains 1 million of these structures called nephrons, and that's why we're called nephrologists, because we look after the nephron. And essentially what this comprises is a filter. So essentially a very, very well-defined sieve that sieves the blood, produces the early urine, then all of that urine flows down this tubule, this plumbing network, and most of what's filtered is reabsorbed by the body. And there are 1 million of these in each kidney. And this is one of those filters in a bit of a larger scale. And essentially that filter is a very, very complicated loop of blood vessels that are microscopic, so you need a microscope to see them. But for 2 organs that are essentially the sizes of my fist, if you were to look at the amount of capillaries in those 2 organs, it would stretch out to 19 kilometres. And so just to put that into perspective, what that would do is if we laid out your capillaries in your kidneys, you'd be able to go from here down to the Tower of London, you'd go and visit Downing Street, you'd come back to Nelson's Column, up to Buckingham Palace and back to the Wellcome Trust. If you laid all the capillaries, the blood vessels that are in your 2 kidneys out in one long length. So that's a phenomenal area that is filtering your blood every second of every minute of every day. So hands up who's had a kidney biopsy. So I have done lots of kidney biopsies and it never hurt me once. But I guess that it wasn't necessarily that much of a nice experience for most of you, and you won't have seen what happened because you were lying on your front. So the only way we can diagnose nearly all of the glomerular diseases is with a kidney biopsy, and that's the only way we can diagnose IgA nephropathy. And so this is what we get at the end of it, which again you're unlikely to have seen because you were swearing on your front, thinking that was more painful than the doctor said. So that's a very small core, a little cylinder of kidney tissue. And normally we take 2 or 3 of these to make sure we have enough tissue to make a diagnosis. And then we look at it under the microscope. And what we see, so this is a section through there, is there's the one side and there's the other side. And those very fine filters are these balls. So these little balls of cells here, each of those, there's 1, 2, 3, 4, 5 filters in that screen. And these are the tubules that then do all the reabsorption. So this is what we're looking at under the microscope to make a diagnosis of what type of kidney disease you might have. And in IgA nephropathy, what we see is that each of those fine filters is full of the protein IgA. So this is that core again. So there's one side of the core, there's the other side. And these are the little fine filters, the balls. And they've been stained for IgA. So every little filter, so all million of the filters in both kidneys is full of this IgA protein. And that's what gives you IgA nephropathy. And if you had IgA vasculitis, it would look exactly the same. There is IgA stuck in those fine filters. So what is IgA? Well, IgA is one of your antibodies. So everyone has it. And what it normally does, it's passed into your spit, into the secretions in your bowel, in your urinary system, in your lungs, to protect you against bacteria. And it essentially coats those surfaces and acts as an antimicrobial paint to stop the bugs getting in. We all have IgA in our bloodstream, but we don't quite know what it does, but it's there. And in IgA nephropathy, there's something subtly different about the IgA that patients have compared to people who don't have the kidney disease. So just some terminology which you will have heard many times. An inflammation of the fine filters, these balls of cells here, is called a glomerulonephritis. Okay? And IgA nephropathy is just one type of glomerulonephritis. There are lots of different types, but that's what we're talking about when we say a glomerulonephritis. And so what does this IgA depositing in the kidney do? Well, my guess is most of you will have been told you've got blood in the urine, hematuria. Some of you may well have actually seen blood when you've picked up a cough or a cold or a stomach upset. And often that urine doesn't look red, like you've cut yourself. It looks like Coca-Cola or it looks like tea. It's got that kind of dark brown colour. Most of you, if not all of you, will have blood in the urine that you can't see, so-called microscopic hematuria, and that can only be seen on a dipstick. And often that's there for the rest of your life. It may come and go a little, but often it's there all the time. And one of the challenges we have is when you feel unwell and someone dips your urine and they don't know you've got a kidney disease, they assume you've got a water infection. Because one of the commonest causes of blood in the urine is a water infection. So it's always worth remembering to tell whoever's dipped your urine that you do know you have a kidney disease, so don't automatically assume it's a water infection. And I really like these pictures. So this is why blood gets in the urine. So this is one of those fine capillary loops, and this is a red blood cell, these very dark things here. And what you can see here is a red blood cell getting through the wall of the blood vessel. So this is rather like me putting my trousers on this morning. You're squeezing in, and you can see here that blood cell is squeezing through the very tiny holes that are in the loops and getting into the urine. And if you've got IgA in the kidney and there's inflammation in these blood vessels, clearly these blood cells are going to be able to get into the urine more easily. And that's why we see blood in the urine. The other thing that we look for and that you may well have is protein in the urine, proteinuria. And again, that's normally identified by a dipstick test. If you have lots and lots of protein in the urine, you can often look when you've had a pee that you've got a real foamy top in the toilet, like a head of beer. And that's associated with lots and lots of protein in the urine. And so often people may well notice that with certain other forms of kidney disease, but that's something that we do see. The other thing is you may well have been shown to have high blood pressure. So some people with IgA nephropathy, it all comes from the fact that for some reason someone's had their blood pressure measured and it's high. And that triggers a series of tests that ultimately lead to you being identified as having IgA nephropathy. And finally, you may have had the joy of a blood test where we check your kidney function, because that's really the only way to know how well your kidneys are working is with a blood test. And we measure the creatinine level in the blood, and then we use that to calculate a number called GFR, which in all intents and purposes we can say is a percentage of your kidney function. So if you have a GFR of 100, that's normal, that's 100%. If you have a GFR of 30, that means your kidneys, both of them, are collectively working at about 30% of what we would expect them to be. But none of these symptoms tell me that you have IgA nephropathy, because they can happen with all sorts of different kidney diseases, and that's why we need the kidney biopsy, which is why all of you had the delight of a kidney biopsy to get the diagnosis. So I guess when Phil runs the patient groups this afternoon, we're going to hear how variable this disease is and how it's affected everyone very differently. And IgA nephropathy is truly a very, very variable disease. And I just want to show you some things. So this is the proportion of kidney biopsies that are diagnosed with IgA nephropathy. So in the West, so we have around 1 in 4 of the kidney biopsies that we do in Leicester has IgA nephropathy on it. If we go out to Southeast Asia, half of them at least are IgA nephropathy. So IgA nephropathy gets much, much more common as you move from the west to the east. And we don't know why. In fact, it's so common in Asia that even the dogs get IgA nephropathy. We don't know why in the UK and other Caucasian countries, 3 times as many men are likely to get IgA nephropathy as ladies. But if we move over to Asia, it's 1-to-1. In fact, some places, women are more likely to get IgA. We just don't understand that. And perhaps the most important thing that we are working on hard in Leicester to try and understand is why everyone in this room will have kidney biopsies that show IgA in the kidney, yet some of you will live your life with normal kidney function. And others, over a period of time, will develop progressive kidney damage and end up needing dialysis or a kidney transplant, despite everyone's biopsy showing the same IgA stuck in the kidney. And that's something that we are working really hard to try and understand so that we can tease out what's different between patients. So what happens with IgA nephropathy? Well, it can go away completely. It doesn't happen very often. More often happens in kids. More likely, you're going to have it for the rest of your life. And in some people, it will cause no issue, no inflammation and scarring to the kidneys, but in others, there will be a slow loss of kidney function as there is gradual inflammation and scarring of the very fine filters. And some, about 20%, 30% of people with IgA will develop significant kidney scarring, meaning that the kidneys stop altogether, in which case you'll need dialysis or a kidney transplant. And for those who have a kidney transplant, there is a potential that the disease will come back in the kidney transplant. And that's because the disease is a disease of the IgA that's circulating in your blood. So if you plumb a new kidney in, that new kidney is exposed to the same IgA that your old kidneys are exposed to. But nearly always in IgA nephropathy, things happen slowly. They happen over years, 10 years, 15 years. Some people, unfortunately, it's very quickly, but in the vast majority, it's a very slow progression, so there's time to think and talk about it. So can we predict what's happening, what will happen? So if you just have blood in the urine, either you see it yourself or it's on a dipstick, you're likely to do very well. The likelihood of you developing progressive kidney scarring is very, very small, unless you live in Asia, in which case there is a risk that even with that very minor changes, you will end up with kidney scarring, again suggesting the disease is very different. The things that get us worried as nephrologists and make us think that kidney scarring may happen is if you've got more protein in the urine, your blood pressure is high, or your kidney blood tests are abnormal. Yeah?
My question of this is, right, what I don't understand is, my understanding of the SID mechanism in the glomerulus is that you know, they're like little holes, and the red blood cells are the protein passing through these little holes into the tubules. But I always understood that protein molecules, you know, albumin, was much smaller than red blood cells.
So it is.
So I don't understand.
Yeah.
Well, I don't understand why if somebody's got blood in the urine, they haven't got really high levels of protein in the urine as well, because red blood cells are bigger than protein.
So you're absolutely right. Red blood cells are much, much bigger than protein molecules. The difference is that the reason protein is more damaging is because the red blood cells going through the kidneys are benign. They don't cause any mischief as they go through the kidneys and come out in the urine. What we know for sure is if you have protein that leaks across the fine filter, it damages the rest of the kidney as it goes down. So the albumin, the protein that's leaking, is interacting with the cells in the rest of the nephron, causing damage as it goes down, whereas the red blood cells just pass through and don't cause any problems at all. So that's why, because we know that even though the protein is a marker of damage to the fine filters, it's also causing damage as it goes down, which is why we really want to reduce the amount of protein that appears in the urine. Because we're not just affecting what happens in the filters, we're affecting what happens in the rest of the kidney as well.
With that point regarding protein, does that mean a low protein diet is ideal for IgA sufferers?
No.
Okay, explain.
So the protein that's getting through is your normal protein that's present. We don't want to reduce the protein in your bloodstream because that's doing lots of important things. There has been lots of interest in low protein diets for people who have have severe kidney disease, and it was thought to be a way of slowing down the progression of all forms of kidney disease. But that data has not held up over time. And so the most important thing in terms of diet, if you have IgA nephropathy, is to have a balanced, healthy diet. You're 5 a day, in line with everyone else in the country. There's no evidence that any particular diet improves your outcome if you have IgA nephropathy or IgA vasculitis. The other thing that we use is we look at your kidney biopsy, and we look at the extent of inflammation and scarring on your kidney biopsy, not just within the filters, but also within the rest of the kidney. And you may or may not have heard of this thing called the Oxford classification, which was developed, unsurprisingly, in Oxford by a team of pathologists and kidney doctors from around the world. So all of the kidney biopsies are now scored using this system. And the importance of this is that next year, we are going to release an app that will allow people to predict the likelihood of them developing progressive kidney scarring using the data from their kidney biopsy and their proteinuria, whether they have high blood pressure, and their level of kidney function. And this is work that the international IgA nephropathy community have done, led by a guy called Sean Barber in Vancouver, and he has data from over 5,000 patients from Japan, China, and the UK. He's put all that information in. He's known what's happened to them over the 5 years from their biopsy, and he's generated a very complicated equation that allows you to use this information to put into an app that is then going to give you a risk of your likelihood of your kidney function getting worse over the next 2, 3, 4, 5 years. So we're just waiting for that scientific paper to be published, and then the app will become available, and it'll be able to be downloaded from the App Store. So I will feed out to everyone when that is out there. It really, at the moment, only applies at the time you have a kidney biopsy, but we're working through the data, or Sean is, to make it relevant if it's a year since you had your biopsy, 2 years since you had your biopsy. So we're making real ground here in being able to give individual patients at the time that they're given the diagnosis a clear idea about what might happen in the future. Yeah?
How about patients that had biopsy done 10 years ago, like in my case? Would you recommend that they have biopsy taken again? So
for me, the most important predictor of the future is what's happened in the past. So what I would do with a patient who has a long history of IgA is I plot out what's happened to your kidney function over time, and I can produce a graph. And normally, kidney function gets worse at a relatively predictable way. And that means that I can predict how much kidney function is being lost per year, and I can predict then when you're likely to hit a level where we need to start thinking about kidney transplants and dialysis.
Okay.
And so most kidney units will have, and in fact on patient view, which I guess a lot of you will have, you can graphically represent your kidney function. And that's essentially what we do in clinic, is we look at the kidney function, and what we're trying to do is slow that rate of loss. But if you've got 10 years worth of data about what's happened to your kidney function, that will help me predict what's going to happen in the future.
All right. Thank you.
So I've covered that. So what's the cause? Now, I could spend the whole day talking about the pathogenesis of this disease, because that's what I do, but I've been told by Karen a limited number of slides. So the bottom line is we don't know. But there are lots of people around the world working really hard to try and find out what the cause of this disease is in IgA vasculitis. We know there's something about the IgA in patients with IgA nephropathy that's subtly different to people who don't have the disease. And this is something that we've done. So this is a single IgA molecule. So we are working down to the level of individual IgA molecules to work out if we can compare the shape of an IgA molecule from someone who doesn't have IgA nephropathy to an IgA molecule for someone who does. And this is, in fact, Phil, who's just sat there. That's his IgA. So that because Phil has given us, I don't know how many litres of blood over the years to help with our research. And so this is the level at which we're working at, to the level of single molecules to try and work out what is different. We also know that there are subtle differences in the way the immune system generates the IgA. And most obviously, I don't know if anyone in the room has had this, a cough or a cold, and within 48 hours you're peeing blood. And that tells us that it's something about the immune system within your respiratory tract or your gut that is abnormal, that is generating this IgA that's depositing in the kidneys. And so there's a lot of work looking at this is the lining of the gut here, to think about what's going on in the gut. Could the kidney disease actually be a red herring? And we're talking about a disease that's primarily involved in the bowel or the lungs, generating the IgA that's causing the problem. And there's a lot of interest in the bacteria that live in the gut. Is that driving this immune system to generate the IgA that then gets stuck in the kidneys? So Chike is just about to start a study where we're going to give a specific probiotic, and we're going to see whether tinkering with the bacteria in the gut alters the type of IgA we see in the bloodstream, to see whether that might be related.
So, is it the small intestine or the large intestine?
Oh, sorry.
Would it be the large bowel or the small bowel?
So all parts of the bowel have the bit of the immune system. The most intense area of the immune system is in the end of the small intestine called the ileum, which is where this is in fact based, which is where all these very, very dense immune cells sit. And there's a new drug that's been tested that was specifically designed to target these immune cells in the gut. And that initial result suggested that this might be a way of treating the disease. So treating the kidney disease by targeting the gut. So what's the right treatment? So the most important thing you should walk away for is we are obsessed with your blood pressure. We need to control your blood pressure because we know whatever the cause of kidney disease, if we control your blood pressure, we can slow the rate it gets worse. And you can control your blood pressure with exercise by being the ideal weight, taking tablets, and salt restriction. So when we did the patient day in Manchester, one of the dietitians gave a really nice talk on salt restriction. And in fact, her video is on the Facebook page. So if you go searching for it, she gives some really sensible, easy advice about things you can do to try and reduce your salt. Because even if you do this, and you take tablets, salt restriction will improve yet again your blood pressure control. We want to reduce the protein in your urine exactly for the reason we discussed, because as protein leaks into the kidneys, it damages the kidneys as it goes down into the urine. Getting your blood pressure down will reduce the amount of protein in your urine. There are particular tablets which I would imagine most of you in the room know about because you're on them.
There's a question on Facebook.
Okay.
And it's somebody's questioning whether ACE and ARB inhibitors are used to treat proteinuria still.
They are. So ACE inhibitors and angiotensin receptor blockers were designed to treat high blood pressure. So we can use them to treat high blood pressure no matter whether you have proteinuria. However, we know that if we treat high blood pressure with another drug, we can get a target blood pressure. If we treat that same patient with one of these drugs and get the same blood pressure, we will get even more protein reduction because of something specific to the way these drugs act. So if you have high blood pressure and you've got protein in the urine, these are the drugs we would want to try first. If you have normal blood pressure and you've got protein in the urine, I will be putting you on one of these as well, because I want to use this to reduce the proteinuria even if you have normal blood pressure. Now clearly the problem there is these tablets are designed to lower your blood pressure and you have normal blood pressure. So the obvious side effect is going to be if I give you too much, your blood pressure is going to come down and you're going to fall over when you stand up, or you're going to feel dizzy. So what we do in that situation is we slowly increase the dose of these drugs to the maximum dose you can tolerate. And that is determined by how well you feel and what your blood pressure does. But even if you've got completely normal blood pressure, we would want you on this to try and reduce the protein.
So I've been on Ramipril for, I don't know, 11 years or something like that. And would that be just basically a normal course of actions taken by a doctor, just give you a Ramipril, or should they also try different one and just measure which one works better in order to reduce proteinuria?
So there's no evidence that any of these are better than any other. So it doesn't matter which one.
Okay.
There was a vogue in the past to use both together, but there have been studies that have come out to suggest that that might not be the right thing to do and might cause other problems. And so the way the international guidelines and what we would recommend is that we would like to have, if you can tolerate, you on either one of these or one of these to the maximum dose that you can take to try and reduce the amount of protein in the urine. If that's not enough to control your blood pressure, we will add additional drugs on, but this is the first one that we would want to use for your blood pressure.
Okay. Thank you.
So is there any specific treatment for IgA nephropathy? So at the moment, unfortunately there isn't. And 5 years ago, we would have thought that actually there was nothing on the horizon. But things have changed dramatically. And now there are 5 or 6 brand new therapies being tested in clinical trials for the treatment of IgA nephropathy. And we hope to move those into IgA vasculitis. So the outlook is absolutely fantastic and completely different to how it was 5 years ago. Some of you may well have been tried on steroids or mycophenolate. If I were to put 100 nephrologists in the room and ask them, would you give steroids or mycophenolate for IgA nephropathy, you would get lots of different answers. And that's because we don't know what the right answer is. So some of you will have had that, some of you won't. And that's simply because we just don't know. The good news is we are doing clinical trials to answer the questions. The only way we know whether a drug truly works and is safe is to do a clinical trial, where we compare the drug against not giving the drug or a placebo. And then we can truly see whether the drug is effective at preventing the kidney scarring and whether it's safe. In your packs is something that I've put out on the Facebook site, but also summarises the clinical research studies that we're doing and tells you the clinical trials that are recruiting at the moment in IgA nephropathy in the UK and the cities, the hospitals that are open for those studies. So you can have a look at those and see whether there's a place near you that might interest you. And come and speak to me at the break if you want to talk about it. I just want to finish off by what's going forward in terms of research, because in the UK we are probably one of the leading countries in IgA nephropathy research. And we're very, very fortunate to have this thing called RADAR, which is a rare disease registry. And IgA nephropathy and IgA vasculitis are part of RADAR. And RADAR is funded in part by Kidney Research UK. And essentially it's a rare disease registry. So at the moment we have over 3,000 patients in the UK with IgA nephropathy in RADAR. And what that means is because we have a single NHS, and we're the only country in the world to have a single healthcare system, if you're in RADAR, every time you have a blood test anywhere, that blood test results will automatically go into RADAR. So what that allows me and other researchers to do is to see what happens to people with this condition over time, to see what happens if you have a kidney transplant, what happens to your kidney function. We could ask a question, do men progress and get kidney failure quicker than women? Do people of different races? Does it matter where you live in the country? We can ask so many different questions because we have the data for a large number of people. And linked with that now, I've been able to get IgA nephropathy and IgA vasculitis onto the NIHR bioresource. Now, this is a centrally funded initiative that allows us to recruit patients. We collect their blood and we look at their DNA, and we are able to link their DNA to their clinical outcome in RADAR. And what that means is what I'm aspiring to is to have every patient with IgA nephropathy and IgA vasculitis in RADAR, and ideally everyone in the bioresource, because that means we will have the DNA, the genetic information about patients, linked to what happens to them real-time clinically. And we will be able to look to see whether there are any particular genetic reasons why some people progress faster than others, genetic reasons why some people get the disease back in their kidney transplant rather than others. And also with the bioresource allows us to contact you and say, we've got a new research study. Could we ask you to come up and be involved? You don't need to come to Leicester. You come to whichever hospital is closest to you that's part of the bioresource, and you can take part in a study. And we can do that within a month. We can say, we need 500 patients with IgA nephropathy because we need a blood sample, because there's something really important we want to study. And this allows us to be able to test that out. And if you want to be if you're interested, you can come and be part of that. And so these are two fantastic UK-specific initiatives that no other country has. and every other country is very, very jealous of. But of course, that doesn't answer the question, why is the disease so different in different parts of the world? So what I've done is we now have an international version of RADAR, this rare disease registry. And I've worked with Adrian, who's got his eyes shut here, from Singapore, and we've developed the Southeast Asian glomerulonephritis group, which is going to bring international RADAR to the Philippines, to Malaysia, Singapore, Thailand, Indonesia. Dina is one of our PhD students, is going to be bringing that into Indonesia. Sasina, who works with us, is going to be bringing this from Vellore in India. And we also have a contact in Hyderabad in India as well, who's going to start collecting data. And we have a sister renal centre in Nantong in China, and they're going to be collecting data. So suddenly you can start thinking, well, wait a minute, this disease is very different in different parts of the world. Let's compare big populations to see what's different. And there we might be able to understand more about the disease. And so I think the future is looking fantastically optimistic in this condition, both because we have new drugs we're testing, we're getting new information, we've got a fantastic collaborative network across the globe with people interested in working together. But it wouldn't be possible without you guys. And the only way we can do our research is with your support, by you being prepared, like Phil, to give half his blood volume and keep coming back for more. So we really are appreciative of your involvement in days like this, but also being involved in the research that we do, being prepared to give us a little bit of blood or urine whenever we ask. So I'm going to finish there. And just to convince you that we do have some fun as well as work hard, this is the team in Buenos Aires. So there was a 50th anniversary conference of IgA nephropathy where experts from around the world came and discussed. And I put a summary of that, or Karen generated a summary, which is on the UK Facebook page, of what was discussed. And this is the team. Some of them are here today. And I just want to finish by thanking the mayors who have been incredibly generous in supporting our work in Leicester to the tune of a number of £1 million to help help us to research IgA nephropathy, along with other donors who are sat in the room who I'm not going to single out because I don't want to embarrass them. But I just want to thank you. As I say, please come and catch us at any time to ask questions. And I'm happy to answer any questions now.
Hello, I'd just like to raise a few questions from our online participants that have come in over your talk. So the first question is a combination of ACE and ARB harmful? So
there have been large studies in older people where a combination of ACE and ARB has been shown to increase the risk of cardiovascular events, so events involving the heart and the circulation to the brain. And so the general guidance now is that we don't use them in combination.
Okay, thank you very much. And our second question is from a participant who is on dialysis now and also on a transplant list. And he has asked, am I right in thinking that IgA has had its wicked way with me and cannot dab into my kidneys anymore?
Absolutely. So once you're on dialysis, the kidneys essentially just sit there, they're scarred, and over time they will stop producing any urine and they just won't cause you any trouble. The issue comes if you have a kidney transplant, is that because the IgA is still circulating around your body, there is a risk that it could deposit back in the new kidney and potentially cause inflammation and scarring. Although the data from the large kidney transplant registries is that if you have IgA nephropathy, you do as well, if not better, than anyone else who has a kidney transplant for any other cause of kidney disease. So it's no reason not to want to have a kidney transplant.
Okay, brilliant. And we've just got a third question. So we've got someone who had a transplant 8 years ago, and they've recently had a biopsy that's shown that the IgA is returning. Do you have any advice for them?
So one of the things to say is that IgA can deposit in those filters. Doesn't necessarily mean it's causing any inflammation, it just means it's deposited there. The key thing, as with the normal disease in your normal kidneys, is to make sure your blood pressure is controlled, make sure you're on the ramipril or a drug like that, or losartan, and speak to your transplant consultant about what they're doing with the immunosuppression. But there is no evidence that any particular immunosuppression, if you've got a kidney transplant, is better or worse if you have IgA nephropathy.
Brilliant, thank you very much.
So that was one question. So is the immunosuppressant still a viable option then, given what you said about it, the IgA depositing in the immune system, immunosuppressant still a viable option?
So we definitely need to target the immune system, but we need to be very clever about how we target it, because the immune system's there for a reason, and the major reason is to stop us dying from infections. One of the recent studies looking at the use of steroids in China had to be stopped because the steroids that were being given to patients with IgA nephropathy were causing too many infections. So steroids are very good at damping down inflammation, they're very good at suppressing the immune system, but they come with a number of side effects. And what we're always doing as doctors, when we discuss with you as patients, is balancing the risks and the benefits of the treatments. And at the moment, it's unclear whether the benefits outweigh the risks or the risks outweigh the benefits for steroids in IgA nephropathy. A number of the new treatments that we're using are very much more targeted therapies to target different aspects of the immune system. And the good thing there is they target the immune system so they don't have as many side effects. But because the new therapies are targeting different bits of the immune system, we could use them together. So if one has an effect but not completely removes the disease, we can add in another one because it's doing something very different. So that's why I think it's very exciting going forward, is that we've got a range of new treatments targeting different bits of the immune system that potentially we could use at the beginning and then the middle, and we could use together. But you're right, we need to be targeting the immune system to switch off this IgA that's then depositing in the filters.
You mentioned, and I can never say the word properly, nephropathy? See, I told you I couldn't say it. IgA nephropathy.
Yeah, nephropathy.
Thank you. And vascular. You didn't explain the difference there.
So,
can someone go from one to the other?
So IgA vasculitis, if you look down a kidney biopsy, they would look identical. But if you have IgA vasculitis, you have disease that affects you outside of the kidney. And so that is often represented by a skin rash, by aches and pains in the joints. It can also lead to inflammation in the lining of the bowel. So that's a very common disease in children. Well, it's the commonest form of inflammation of the blood vessels in children. It's less common in adults. But in terms of the kidney disease, it's very similar to what we see in IgA nephropathy. But for some reason, they have a disease that also affects bits of the body outside of the kidneys. And so one of the things that we're interested in is working out what's different about the two diseases. Because the kidney disease looks identical. But for people with IgA vasculitis, they have this additional issue, which is that there's inflammation in blood vessels outside of the kidneys. So it's an interesting relationship. So there are people who've had identical twins. One's had IgA nephropathy and the other one's had IgA vasculitis. You have people that are told they've got IgA nephropathy, but actually on the Facebook group, we had a bit of a conversation. And actually, in hindsight, some of these people actually remembered having a rash that was very typical of it some time ago, but then it disappeared. And then they came and presented to the doctor, and they had the biopsy, forgot to say about the rash, or said about the rash, and it wasn't noted, and they've been labelled as having IgA nephropathy. So it is very mixed. The rash can occur before you have the kidney disease, it can occur after you have the kidney disease, or it can occur at the same time. And only by talking to someone and taking a really detailed history do you work out whether they actually have a rash that's related to this or not. So it can be quite muddled in terms of getting the diagnosis absolutely right. And we don't have a test to distinguish one from the other.
Could you just explain the term scarring? Is it the same as inflammation?
So what happens normally is the process is the IgA gets deposited, And often there's this inflammation. So rather like if you have an inflammation in the skin and it's very inflamed, red, there's lots of blood flowing there, you get that happening inside in the very fine filters. So you get lots of inflammation there, which we can see down the microscope. You wouldn't notice it necessarily. But if that inflammation doesn't resolve normally, it resolves by scarring. And scar is just dead tissue. It doesn't do anything. So that ball of cells that was doing all that work suddenly gets replaced by a scar that does nothing. So what you have is you have this appearance of inflammation, which in some people settles down and the structure of the filter remains the same. And in others, it goes to the point where it just carries on to the point that there's just scar tissue. And essentially what you look at, if I were to put up a picture of a kidney with scar tissue, those round balls would have no cells in it. It would just be a pink blob, which is just the scar, just like if you cut yourself and you had a scar. It's just essentially concrete that's replaced this functioning tissue. No, unfortunately, so that's the holy grail. So can we stop the inflammation progressing to scarring is what we want to achieve, or can we stop the inflammation in the first place? But once the scar tissue's there, it's there for good, and we can't do anything about that. Okay.
Can we just take one last question and then...
Are we overrunning? Yeah. Okay.
Thank you. I had a question about treatment, if that's okay. I had a biopsy about a year ago, and I was put on ramipril. My blood pressure was normal, but I had a lot of adverse effects from the drug, mainly dreadful memory loss, not being able to even complete a sentence. I spoke to my nephrologist and he transferred me to Candesartan. Some of the symptoms have gone, but I still have issues with memory. Is that an effect of the drug or is that an effect of the disease?
So it's certainly not an effect of the disease because IgA nephropathy is very much a kidney disease with nothing else happening outside. In terms of the fact that this thing starts and stops when you take your tablets, it strikes me it's much more likely to be related to the medication. And whether that's related to affecting the blood circulation going to the brain or whether it's something different, I just don't know. What we try and do, so clearly when we give treatments, we don't want to make patients feel worse than they were before they had, because we've not done a very good job. So we always have to balance the benefit of you taking the drug against how that makes you feel. And we have to get a fine balance that you're happy with and that we think is trying to do as much protection to the kidney as possible.
Okay, thanks very much. Thank you very much, John. Sure, okay. And I'm sure John's going to be available for more questions later on. Okay, next I'm very happy to introduce Dr. Sharlene Greenwood. Sharlene is a consultant physiotherapist and senior lecturer in renal and exercise rehabilitation at King's College, London, leads several research projects looking at kidney and heart disease and physical activity, and is going to give us a talk on lifestyle and kidney disease. Thanks very much.
Okay, so thank you very much for inviting me along. It's a real pleasure to be here today to come and talk to you about my favourite subject, which is lifestyle. And so what is it that we're going to talk about today? So before I mention that, I'm going to get everybody to stand up, okay? Because that's partly because I'm a physio, but there's also something behind that as well. So everyone just stand up. I'm going to stay standing up for a second, or 2 or 3 or 4 or 5. Good, okay. All right. Well, can anybody tell me why I'm asking you to stand up? Anybody know why?
Is it healthier for you?
Yeah, healthier. You've probably all seen in the press, haven't you, that if you people are having meetings now, standing up, partly because it gets the meetings done quicker, but it's also healthier for us to be standing up. Any other reasons? Concentration. So I want you to be able to concentrate. You've already been sitting down for an hour, so I want you to be able to concentrate. There was another one?
Circulation.
Yeah, absolutely. The circulation, lovely. There's also been some good studies which have been done which shows that you burn calories just by standing up. So as we've been standing here now, we've all burnt a calorie. So that's worth it. Might not help if you have a biscuit in your break, but it all counts and it's all worth it. Okay, everyone have a seat. Lovely, thank you. So hopefully you're all feeling a bit more energetic now. So what is it that I'm going to talk about today? So we're going to talk about exercise or physical activity, and there is a difference between the two, and I'm going to quickly tell you what they are. So physical activity, any bodily type of movement, so gardening, walking, all those types of things. Exercise, more structured activity, so organised, rhythmical, structured activity of the body. Okay, so those two kind of get interchanged, and I'll be interchanging them a little bit as well. So I'm here to talk to you about exercise and lifestyle and why it's important, especially if you've got some problems with your kidneys. What I'm not going to talk to you about and get you to do is to look like that, because nobody really wants to look like that, and it's practically impossible to look like that. Okay, so what is it that we're going to talk about? We're going to talk about the importance of lifestyle and the kidney. So we'll talk a little bit about why we need to do this, what's happening with the kidney in the body. We're going to talk about recommendations. So what are the recommendations out there for people who've got kidney disease to do exercise and physical activity? And then I'm going to talk through some of the exercise and physical activity options. So things that are available, things that you might want to do, and things that you've got a choice of taking part in. And why am I the best person to be here to talk to you about this? Well, I've been a physio now looking after patients with kidney disease for coming up 17, nearly 18 years. So over the time, I've been encouraging patients to exercise and also looking after people who are overweight. And what I've hopefully picked up is some good tips, which I can hopefully share with you today. Okay, so what is it about kidney disease and the body that we need to know about? So John just in a really lovely and succinct way, talked to us about what happens with IgA nephropathy and kidney disease. I'm going to talk a little bit more generally and say that when we've got kidney problems and our kidneys stop working so well, there are certain things that happen in the body. One of those is muscle wasting. Okay, so that happens as we get older anyway. So people might have heard of the term sarcopenia, and that's age-related muscle wasting. It also happens when we don't use our muscles. So if we sit too much, hence standing up, get moving. So if we sit too much and we don't use our muscles, they get smaller. But also, to do with the kidneys not working so well, John mentioned this inflammation and also build-up of toxins, and that can also damage the muscle fibers and make the muscles work a little bit less than what we would like them to do. Bone density, okay, so again, the kidneys, they balance those important minerals, and because the kidneys might not be working as well, sometimes some people can start to develop problems with their bone density. Fatigue, okay, so fatigue, that can be physical fatigue, so feeling lethargic, also mental fatigue, lack of motivation. These are all things which people say are quite common. Some of my patients tell me are quite common in kidney disease. And then also cardiovascular disease risk. So we were talking about blood pressure. So blood pressure is one of the big things which is affected with kidney disease. So we get higher blood pressure. This increases the risk of getting cardiovascular disease. Okay, so we need to look at ways that we can help to reduce that risk. So why is it that inactivity makes you feel worse? Okay, so I'm going to start at the top there and say you feel breathless and unfit. So because you feel breathless and unfit, you do less activity. And because you do less activity, coming around the side here, I'll try and get this pointed to work, your fitness level decreases. And as that decreases, your muscles get weaker, so not using your muscles. And then you get more breathless and more unfit, and we start this circle off again, so you do less, you get more unfit. Okay, so this is called the cycle of decline, and it affects everybody that doesn't use their muscles and get active. So this is where you've all got to, I'm glad I woke you all up because this is where you've all got to get involved. Okay, so why exercise? What does exercise do?
Improves cardiovascular fitness.
Absolutely.
Builds muscles.
Builds up your muscles, makes them stronger. Lovely.
Pumps blood.
Pumps blood, so improves your circulation. Yep.
Bone strength.
Bone strength. Lovely. Yep.
Burns calories.
Burns calories. Absolutely, makes you feel better. Okay, you've all probably experienced that bit of a high that you get when you've been out, especially if you go out on, say, a cold, wet morning, and you come back in again, have a shower. You feel quite good, don't you? You feel quite good with yourself. What other things?
I don't know, just guessing how it's removing weight out the body through the sweat.
Helps you losing weight.
Body weight through the sweat.
So it does help, it does make you sweat, and it does help you lose, it's probably not through losing the sweat, but yes, indeed, in terms of when you sweat, you know you're at an activity level where you're getting rid of the calories. Yeah, so they're definitely linked. Anything else? Any other things? Should we have a look and see what's on my list? So yeah, feel stronger. Heart health, so cardiovascular disease risk. Quality of life. So linked in with feeling better, wanting to get out, do more, meet more people. Blood pressure control. So this was a big one that John mentioned, wasn't it? So we know that exercise helps to lower your blood pressure. Chronic exercise use does. Diabetes control as well. Okay. Mental health, bone density, help to control your cholesterol, reduce breathlessness, and then, yeah, weight control. A couple of people mentioned that. And that brings me on to this. Has everybody seen the energy balance before? Yeah. So if you're at the top there, you're in the weight maintenance, you've got weight gain and weight loss, and it's all to do, isn't it, with how much food you take in and how much energy expenditure you take out the other side, so how much activity you do. And it's about balancing those two things that helps you maintain your weight. But if you want to lose weight, and we know that losing weight is if you are overweight, it's a good thing to lose some weight. It's good for your kidneys, it's good for your heart, it's good for your muscles. So if you want to lose some weight, you've got to shift that balance. You've got to eat less and you've got to move more. Okay, what's difficult about starting to do exercise? I'm sure this must be one that everybody's got lots of things to say on. Lack of time, absolutely. So I have people who come to see me who go on dialysis 3 times a week, and then we're trying to get them to fit in exercise around that. So it's quite difficult, and you've got lots of things going on. What else? Confidence, yeah. Yeah, absolutely. So confidence with where to start. Is it okay? But also, if somebody's telling you to go in a gym full of people you don't know, takes a little bit of confidence, doesn't it, to go in that sort of environment. What else?
When you first start, it's hard work.
Yeah, it's hard work.
It's not fun.
It's not fun, no. It's the feeling afterwards that's good, but yeah, it's not fun at the time. Although you can make it fun while you're doing it, but no, I know. I don't think if anybody says exercise, what's your favourite thing to do? Not many people put their hand up and say exercise. Yes?
For me, it's coping with it every time. It takes me a long time to recover. I feel okay, I get that high after I finished it, and then, the next 2 days, I'm just like, destroyed.
Wiped out, yeah.
Still destroyed now after yesterday morning.
Yeah, so fatigue. So, yeah, absolutely.
And then you've got to do it again.
Yeah.
So you spend your whole life being tired.
Yeah.
If you don't exercise, if you didn't exercise, I'm not tired.
Yeah. So if you don't exercise, you don't feel tired. Okay. So.
I'm hopefully trying to change this.
Yeah.
Sort of build up some endurance.
Yes, absolutely. Yeah. But it might be worth looking at what you're doing, and that might be something to do on an individual basis, to look at how you shouldn't feel tired all the time with it. So, anything else? Feel lazy? Yeah. Takes motivation, doesn't it? I don't think there is anybody, maybe some of our elite athletes, that get out of bed and go, I want to exercise. I don't think anybody does that. So, yeah, it takes motivation. Yeah.
If you decide to join a gym, it can be expensive.
Absolutely, yeah. It's difficult, isn't it? Facilities, so you either go to a gym, you go outside. What happens with outside in this country? Although, I mean, the weather over the summer was absolutely glorious, but then maybe it was too hot to be outside exercising. Yeah. Any other things? Should we see what some of my patients have come up with? So weight management and fluid. Lots of hospital appointments. So we mentioned time, didn't we? The weather being unpredictable. Feeling tired? Yeah. What if it makes my kidneys worse? Does anybody here... no, I'm not going to get anybody to put up their hands, but a lot of people come to see me and they say, well, I'm worried about exercising because what happens if it makes my kidney condition worse? And that's quite a common one, and that's natural for us to feel nervous about doing things when we've got a kidney disease. Muscles feeling weak, so like you said, it's hard to start, isn't it? So if you feel weak, where do you get the energy to start and get going? And the side effects of some of the medications as well. So what are the recommendations? Now, we don't have kidney-specific ones as yet because there's lots of research studies that are going on, but we know from the research studies that have been done in exercise and kidney disease that we can say that exercise is safe and that we definitely want you to be doing more of it. But what we do is we go with some of the more general guidelines, and this is the guidelines that I'm going to share with you, which is the Start Active, Stay Active, and this is across the whole of the United Kingdom. So what do these ones say? Okay, so we're just looking at adults. Adults should aim to be active daily, okay? So don't want anybody sitting down during the day. We want you to get up and move around, okay? Over a week, your activity should add up to at least 150 minutes of moderate intensity activity in bouts of 10 minutes or more. Now that can be in anything. That can be gardening, that can be walking, okay? But the research shows that you're looking for that sort of volume of exercise to get the benefits, okay? So all of the things that we've talked about just earlier in terms of the good things about exercise, you get those by doing a good amount of exercise, okay? Or if you can't manage to do this on 5 days of the week or over the week, you can do 75 minutes, so you can do half of that, but you've got to do it at a slightly more intense level, okay? So rather than your gardening, this is looking more at a bit of jogging or going down to the gym and getting your heart rate up so that you're feeling sweaty, okay? Muscle strength activity on at least a couple of days of the week, okay? So this can be just having some weights at home, okay? Doing some, progressive weights with a 1, 2, 3 kg weights. It can be going down the gym, but we know, especially for the bone health, that it's really important to be adding in a couple of days a week where you're doing some strength exercises. And this is showing, some of the recent studies coming out are showing more and more that just not sitting, not being sedentary is really, really important. Okay, so just getting up and moving around is really, really important for our health. Looking at older adults, so adults who are 65 years and over, there's an additional one which is added, and that's to incorporate physical activity that improves balance and coordination on at least a couple of days of the week. And this is especially important in people who are experiencing falls. Okay, and the important thing about this one is that you may find lots and lots of information in terms of, okay, stand on one leg, stand both, feet like this, and all of those are really, really good, but there is lots of information out there now and lots of programs which are doing dynamic types of balance activities, and those are really, really good to look out for because very, very few people fall because they're doing this at home, yeah? They fall because they're reaching to pick something up or they're turning round to do something. So trying to do some dynamic type of balance training is really good on a couple of days a week. Okay, so when thinking about what type of activity is right for you, so we don't all enjoy the same things, do we? Everyone's different. It's part of our variety that makes us all special and makes us all interesting to each other. So we need to have a bit of a think about what type of activity might be right for us on an individual basis. So these are just some questions just to start you thinking about what might be right for you. Okay, so how much time do you have? So if you're somebody that's at work 5 days of the week and is getting up early in the morning and going to bed, coming home exhausted and going to bed, that really limits the amount of time. So you need to find something that you can do, maybe at the weekend, or something you can do in your living room, maybe before you go to work or when you come home. Okay. Are you highly self-motivated? So are you one of these people that can set a plan and say, I'm going to do this and I'm going to do this then, and stick to it? If you are, then, joining something which, is more on an individual basis, or going out for a run on your own might be something that suits you. This is a really important one. Is there something particular that you enjoy doing? So it might be something that you did a while back, which you really enjoyed, and you think you might like to start doing again. So I know lots of people that have taken up older football teams. They've enjoyed playing football in their youth, and they've gone back to doing some slightly older football playing. Do you like to attend groups? Do you like to exercise with other people? Do you like to have other people that are in the same boat? Or maybe I particularly like exercising where I've got somebody that's doing better than me, because it makes me want to exercise as well as they're doing. So that's my motivation. Do you need some help to start exercising? Do you need to, or would you like to be offered something where you go along and get some help from a physio or a trained exercise specialist in terms of giving you some advice? Healthy walks with pedometers. So you've probably all seen, you can get pedometers with just about everything nowadays, okay? And they do vary in terms of how accurate they are, but generally they all do the same thing. The cheap ones, the more expensive ones. So they all give you a bit of motivation to see how much you're doing of something, okay? So if that's what gets you going, pop it on, have a look, set yourself a target, and that's a good thing to do. The other thing is active, healthy lifestyles. Lots of councils run walking groups, and that might be something that you'd like to get involved in. So you can check with your local council for that. The other thing is exercise on referral. Has anyone here been through exercise on referral? Yeah? Yeah? So you can go and see your GP, or you can see your physio or your doctor, and you can be prescribed exercise, which is the way I think it should be. Where, it's a good thing. We know it's good for us to get prescribed exercise. And that means that you go to a local centre, and you will be inducted, and you'll be offered a much cheaper rate of attending either a class or a gym program, and you'll get some supervision to start with to get you going, and then it'll be on a more individual basis. So do speak to your doctor if that's something you're interested in. And swimming and cycling, okay, so more individualised activities, but quite often get asked, is it safe? Can I go swimming? Can I cycle? Absolutely, yeah. Some people like exercising at home. We've produced a home exercise diary that our patients do at home, okay, and they can progress through, follow a warm-up and a little bit of an exercise circuit and a cool-down. And some people much prefer doing that. It fits around all of their activities. They don't want to come in and see us and do a class in the hospital. And fitness apps. Who looks on their iPhone? Yeah? Yeah? This is becoming much, much more common. It's brilliant. Does everybody know that they've got, I know not everybody necessarily has an iPhone, but does everybody who does have one know that you can just go onto your health app and it's telling you how many steps you've done? Yeah? Yeah? So it's a really, really good one. You can just keep it on you, and you can have a look and see. It tells you how many stairs you've been up and everything else. So these are getting much more used. And this one in the middle is a really, really, really good one, which is your Couch to 5K. Okay, this gives you lots and lots of motivation. It has somebody talking to you and helping you through a program of going from not doing very much to hopefully being able to complete 5Ks. So this is something we run at our hospital. It's a specific renal rehabilitation program, so for patients with chronic kidney disease, but it's based very much on cardiac rehab. So that's something else which is an option if it's something that's available in your hospital. So how do we know if we're exercising at the right level? I think the gentleman at the back had one of the things, which was get a bit hot and a bit sweaty. How do you know in terms of your breathlessness? How would you feel? How do you think you should be feeling? Who, on that scale, where do you think? If I showed you that scale and said, the green one? Yeah, yeah. Colour-coded. So yeah, so we're aiming for somewhat hard. And do you know what somewhat hard, does everybody know what somewhat hard feels like? Because it's personal to everybody. But it feels like you, it sounds like if you were to say a sentence, so if you were to say, I hope this exercise is going to be good for me, you would be able to say the sentence, but you'd have to have some breaths in between. So you'd be, I hope this exercise is going to be good for me. Okay, so that's a really simple way for you to test when you're out walking or you're out doing whatever activity it is that you want to get the benefits from doing, is to say, if I say that sentence, you don't have to necessarily say it out loud in front of a whole load of people. Maybe wait until you've gone around the corner. But if you say it out loud, are you breathless in between? If you're not breathless, speed up, add in a hill. We're very clever. Our bodies are incredibly clever. They accommodate really, really quickly. So what we might be doing 1 week, 2 weeks later, suddenly we're not feeling that breathless anymore. And that's great because it means we're progressing, but it also means that we have to push the boundary. And that can be through, as I say, going quicker, going for longer, or making it more difficult. So adding in a hill or doing something to make it so that you're more breathless. So now you've decided that you want to do a program, how are you going to stick with it? Because there's lots of things that come into our daily lives, isn't it? So these are just some tips. So support. So doctors and nurses, you know, if you want to do it, talk to whoever you see in clinic, or family, friends. Get some support, get some motivation. Tell somebody you're going to the class next week so that you know that they're going to ask you, how was the class? Did you enjoy the class? Okay. Facilities and equipment. Okay, if you want to be somebody who does something at home, you know, go out and get your weights. Okay, do very, very cheap set in Argos. You can get some band. You can do a whole load of things off YouTube. Okay, so that's a really, really simple way of doing it. Really important is for it to be enjoyable. Okay, so find something that to you is going to be enjoyable. And it might not be the thing that your best mate enjoys and is trying to drag you out on. It might mean making a different choice, meeting somebody else that likes the thing that you enjoy doing. Plan. Now, this is a really big thing. We plan our food, don't we? So we plan when we're going to go shopping or we're doing the food order, what meals we're going to have in our week. Okay, and that comes quite naturally to us. We need to be doing the same thing with our exercise. So plan ahead, have a look at which days are busy, which days you might feel more tired, and when you're going to try and fit it in. If you can, put it in your diary if you've got a phone. Maybe put an alert on. Move it if it gets, don't take it out, but move it if something comes up where you've got a conflicting arrangement. Really important to look at your progress. So fitness tests are good if you're involved with physios or you're involved with somebody that can do you a fitness test. But also just that, at home, when you're out, you'll be able to notice, see how many steps you've done, see how long it's taken you, whether you can do it in a shorter amount of time. Those are all simple tests you can do to show yourself that you've improved, okay? And if we don't see that we're improving and we're getting the benefits, we lose the motivation, don't we, to want to do things. Okay. So how to minimize the risks of injury from exercise training. So if you're worried, and I will stand up here and say, I've been working with patients for as long as I have done, and it's safe and it's enjoyable. But if you're nervous or you want some extra information, talk to your doctor or your physio, or talk to somebody who's got a background in exercise. Start slowly and progress gradually. I would never say to somebody that's not been doing very much exercise, go out and have a run, okay? Go out, do a walk, progress your walk, start a slow jog, end up in a run. Okay, so slowly, slowly progressing. Really important to warm up and cool down. And I'll put alongside that wearing appropriate footwear and appropriate clothing. If you're going to go out and walk outside in this country, you might want to have a light jacket on, but not something that's going to make you too hot. Okay, so really have a think about how you're going to be comfortable and how you're going to be happy when you're out doing whatever it is that you're going to be doing. Most important thing is to remember that not taking part is more of a risk than taking part. Okay, so that's really important. And now with all that information, it's about you deciding whether the benefits and what exercise and adding exercise and physical activity into your day is going to give you, and balance it against the things which are hard and things which are making it difficult to start. And if you can get that balance to tip in favour of that it's going to be a good thing to do, then you're ready to make that change. Okay? If it's not there yet, find out that information. Find out if there are things available in your local area. Tip that balance, get ready to change, and then the most important thing is to just make that change, make that first step. So that brings me to the end of my talk. So what we've talked about today is the good things about exercise, why exercise can be difficult, why it's important to maintain a healthy weight, that there's lots and lots of individual options out there. It's a personal choice as to what things we enjoy. It takes motivation, it takes planning, but it is achievable and everybody can exercise. So I'll leave you with that message and say thank you very much. Any questions?
Have you heard about 7 minutes workout? And do you recommend it as well?
Oh, the 7 minutes, did you say the
7 minutes workout?
Yeah. So there's lots of those types of things. You mean like on the YouTube? Or?
Yeah, there's apps and...
Yeah, absolutely. I think, you know, it's one of those things, whatever's going to suit you, do. The only thing I would mention is make sure that you're already at a basic level before you start doing some of those. Some of them are quite rigorous and, you know, they'll start off with jogging as being the first thing you ever do. But as long as, you know, maybe have a look at what it is, and if you feel ready to do that, I think whatever it is that you can do that gets you active, absolutely, brilliant.
Could you say something about exercise post-transplant?
Yeah.
The reason I ask is that prior to my transplant, I was going to the gym 3 times a week and was absolutely fine. Yeah. And when I was allowed in again 4 months after my transplant, I mean, I started off fairly slowly. The first thing I did was a bit of swimming, and I used to do a lot of distance swimming. Okay. And I swam 10 lengths and thought I was dying. And then when I got back into the gym to do cardio work and resistance work, I was pathetic. And it's, you know, it's getting better now, but I couldn't believe how much condition I'd lost in those times. Partly, I think it might be to do with drugs, but it's also to do with lack of doing anything for 4 months, really. So could you say something about getting condition back again?
Yeah, absolutely. So it's really, really important, and once you've had your kidney transplant, to start adding in some exercise quite gradually. What we say, so we work in the kidney transplant clinic in my hospital, and what we generally say is that from 6 weeks to start adding in some activity, not structured exercise, and then, that's straight after your transplant, and then once you get to 6 weeks, we're quite keen for you to start upping that activity, so you're not having quite so long of being inactive. Because you're quite right, it's the inactivity that makes your muscles a little bit smaller and a little bit less strong. In terms of regaining the condition, it is about balancing doing some of those activities against maybe feeling a bit fatigued, and that can be, so some of the medications can make you feel a bit fatigued. They also make you feel a bit hungry, and so some people struggle a little bit with weight gain as well after kidney transplantation. So important to start slowly and progress, but there's no reason why you can't keep adding in and get back to the same level that you were, if not better, than you were pre-kidney transplantation. But you're absolutely right, it'll be the length of time that you've not been in the gym and coupled with some of the medications. And also, did anybody say to you it's okay to exercise after your kidney transplant?
I was told it was okay to go back into the gym when the time came right, but it was just, not in terms of exercise after the transplant, but it was, people were saying just make sure you're active, make sure you're walking, make sure you're standing a lot and doing those sort of things.
Yeah.
So I wasn't given a lot of guidance as to what I ought to be doing.
Yeah. So I think the really important thing is that it's safe. It's safe and it doesn't harm the kidney. And I think a lot of people get given a, you know, they have that new kidney and it's very, very precious and people don't want to damage it. So yeah, the message is it's safe, gradual, but you should be able to get even better than you were before kidney transplant.
Hello. A few people online are asking about IgA specifically. Are there any specific forms of exercise that you think people with IgA or high proteinuria shouldn't be doing?
So it's not something that's been extensively studied, but there has been a couple of small studies which have been done, which have looked at people doing quite a good amount of activity and seeing the result afterwards in terms of if it's damaging and haven't shown that it's damaging. So I don't know whether you would agree, John. I would say that exercise is something which is very good and essential. And yeah, any type of activity that, again, it's the moderately breathless, it's trying to get to that level to get you the benefits, but there's nothing specific to either avoid or specifically to IgA.
Thank you very much.
Okay. Thank you all very much.
Thank you.
So we've got three talks before lunch. So if everyone would like to stand up, have a wander around for a bit, just while we get set up, just because otherwise you're sitting for a long time. excuse me, could Brooke Johnson... oh, it's not on. Is Brooke Johnson in the room? No? Well, it's okay for me to hide my memory stick, isn't it? Yeah. To leave it? To take it off. Or is it...
Oh, is it somebody else's?
It's mine. It's somebody else's laptop. I'll just not go and leave it here. Yeah. Okay.
Okay, I think we'd better make a start. Should we make a start now? Otherwise, I think lunch is going to be pretty late. I'm sure you'll be keen for that. I'm very pleased to introduce Dr. Tom Oates now. Tom's a consultant kidney specialist at the Royal London Hospital. Has a strong interest in medical education, especially in using social media. I'm sure he's going to give a very stimulating talk on social media, empowering patients and engaging professionals. Thanks very much.
Well, thanks very much. Good morning. Hello, my name is Tom. I think the programme says I work at the Royal Free, but I actually work at the Royal London, which is in Whitechapel in the East End. And those of you who are from London will know that Hampstead and Whitechapel are fairly different. And those of you who aren't from London, hello. Can I have a loan? I'm going to talk about social media. And I've been talking about social media to healthcare audiences for quite a long time now. And I used to have to start by defining what social media is. But I don't have to do that anymore because I don't really know who Kylie Jenner is or what she does. But I know that this is her thumb. And I know that this is her newborn baby. And I know that when she put this photo on Instagram, 18 million people liked it. So that number by itself kind of gives you an idea that if social media is not part of your day-to-day life, it's a part of the life of a lot of people on the planet. And it's certainly a part of how you see the world now, whether you have an Instagram account or a Facebook account or a Twitter account. It influences how you see the world. And a lot of people think that's a bad thing, and in many ways it is a bad thing, but there are some good things about it. So I can't think of any other way that you could be planning your wedding and you could think, I'm going to ask my favourite actor if he'll come and officiate at my wedding. So for those of you who watch Netflix, this is Hopper from Stranger Things, and this lady tweeted him and said, will you come and marry me to my fiancé? And he said, well, if you get 125,000 retweets, I'll consider it. And you'll see she's well on the way here. And she actually got there, and this chap, who's a Hollywood actor, came and married her to her fiancé. Or maybe you're just a very bored teenager in Arizona, and you're a bit hungry, and you like Wendy's, which is a bit like McDonald's, and you sort of do a tweet for your friends saying, how many retweets for a year of free chicken nuggets? And you get lucky because the guy doing the Wendy's Twitter account that day is quite quick, and he says 18 million, ha ha ha. He didn't get 18 million, but he got 7 million. So Wendy's clearly thought that was very good publicity, as it was, and gave him a year of free chicken nuggets. So it was good for him. Now, everyone loves a bit of audience participation, so who's the most followed person on Instagram? Is it Justin Bieber, Taylor Swift, Madonna? I put that one in for the oldies in the room like me, just so they knew who one person was. Cristiano Ronaldo or Selena Gomez? Anyone want to have a go? So it's actually Ronaldo, which I think sort of, if anything, shows that football has now finally permeated America and the Far East. But up until very recently, it was this lady, Selena Gomez. Selena Gomez is an actress and a singer and a former girlfriend of Justin Bieber. And some of you may know that in September last year, she announced that she had lupus, that she had very advanced chronic kidney disease, and that she'd actually had a live donor transplant. And the way she did that is she did it with an Instagram photo, and this is her live donor, Francia. And at that point, she was the most followed person on Instagram. And the way I bring this up is because it's a lovely story, but also because it's kind of an illustration into the fact that we in nephrology, renal, kidney medicine, whatever word you want to describe our community, are actually one of the most well-developed, active, mature, useful social media communities in health on the internet. How did that come about? Well, it came about mostly from this guy, Joel, who's a friend of mine who's a nephrologist in Detroit in the US. And many years ago, when social media was just becoming a thing, he realized that actually he'd been going around hospitals in the US and finding out that a lot of other doctors are a bit scared of nephrology, they're a bit scared of kidney medicine, they're a bit scared of looking after the patients because they're seen as to be being very complicated and things. And he thought that actually using social media platforms, which at that time was mostly Facebook, was a very easy way to make fun, free education available to other healthcare professionals so they could upskill a bit in how they think about kidneys. And over the years, we've really developed that now, and we get asked to write articles in medical journals and stuff about how we've done it. And not only are we using this now to try and teach other other healthcare professionals, we also use it mostly so I can speak about nephrology to colleagues in Mexico, India, Australia, New Zealand, Singapore, France, Spain, Italy, through my mobile phone in real time. And that is incredibly powerful. I don't give away patient details or anything like that. I talk in general terms. We think about how we do things. And we've all learned a huge amount from that. And that Matt, who works with John in Leicester, and I wrote an article last year saying that social media in medicine, I think, is really going to change the game for us healthcare professionals about how we learn and improve what we do. Now, you as patients are probably sitting there wondering, oh, great, am I going to be able to send a message on Facebook Messenger or whatever to my consultant to ask them about my blood pressure or whatever? And that may come, but I think at the moment, if you ask healthcare professionals about interacting with their patients through social media, they probably have an idea of this come up in their head. Because it's still sort of the Wild West, I think, in terms of interacting with patients through social media. It's not regulated. Healthcare professionals don't really know what they can and can't do. They don't know how they would know that they're doing it well or how they would be able to improve. So I think for now, this is probably not where it's at in terms of healthcare professionals and patients being able to talk. But it will come. How can I be so sure? Well, this is the mandate to the NHS, which was written in 2015. It's a sort of long, boring political document. Is there a non-long, boring political document? Anyway, and it says, the NHS really needs to learn to support people with health conditions by embracing opportunities created by technology. And more importantly, we need to achieve a significant increase in the use of technology to support people to manage their own health, okay? 2015 was quite a long time ago in politics. We now have a Secretary of State for Health whose one thing he talks about is data, digital and technology in the NHS. And this report came out a month ago and has kind of laid out how we're going to do this, how we're going to get digital and technological platforms in the NHS and how we're going to support patients more. So there is so much political push behind this that it will happen that we are using novel platforms to speak to you, okay? Now, if you spend any amount of time around social media, you can realize fairly quickly that any group who are interested in something and talking about something are talking about it on social media. And that most of the things groups say on social media is open and free and visible. And therefore that makes social networking sites essentially databases of people's opinions. And you can find posts relating to pretty much anything you want and filter out noise and find out what people are thinking. That's obviously become very well known after Facebook, Cambridge Analytica, Trump, Brexit, etc. because you may think Google is the best search engine, you may think Facebook is a social networking site. In fact, they're the two world's biggest advertising companies, because what they do is they take all the information that you give them freely, and they create a profile of everybody who gives them information, and then they sell that to companies who can then target you specifically, because you're logged into your Facebook account, to target advertising to you. So that's why when you type black shoes on Google, next time you go on the Guardian website or something, there's loads of adverts for black shoes. Don't get caught out when you're buying your wife's birthday present. Now, and this has obviously become a very hot topic, and that's great, but it also was slightly difficult for us, because a couple of years ago, we realised this about social media, and we thought, well, we can go on social media, we can find a whole load of posts about kidney disease, and we can work out what people are saying, what patients are saying, and we can find out what they want to know, what they need to know, what they don't think we're telling them, and how they want to be told it. And so John, Paula Ormandy, who's in Salford, a whole load of other people in Leicester and Salford, and me from London, decided, well, let's look at something more specific. Let's look at IgA nephropathy. And we went to Kidney Research UK and we asked for a small grant, and they gave it to us. And so what we did is we found about 3,000 Twitter posts and about 300 Instagram posts about people talking specifically about IgA nephropathy. We were then, through John's negotiation, allowed completely anonymised and untraceable access to the IgA Nephropathy UK Facebook group, where we had about 2,000 posts of people talking about IgA nephropathy. And all we did is we used sort of established techniques to work out what the specific kind of thematic headings were that people were talking about with regards to IgA. So we could look at that social media and data and say, okay, this is what people think they need to know, this is what people think they already know, and how can we make that better? And what's interesting about that is historically, if we as healthcare professionals wanted to find out about what you thought, what you knew, what you wanted to know, we invited a whole load of you to a focus group. And normally the people who get invited to focus groups are a certain type of patient who's often had the disease for a long time, often knows a lot about it anyway, and therefore we thought it'd be quite interesting to have a focus group and then see the differences between the two approaches, and then let the two of those kind of inform each other and see where the real areas of unmet need were. And we wrote about this in a medical journal, so hopefully people are going to apply this approach in other healthcare diseases. So what did we find? Well, we had the focus group first, and these are the 6 areas that people came up with in terms of what they felt they needed to know about and what maybe we needed to do better at telling them about. So the diagnosis. How is the diagnosis made? What does the diagnosis mean? How is the disease going to progress, and what sort of different stages are there? Diet. Does diet affect the disease? Do I need to change my diet? The treatments I'm being offered, what do they actually do? How do they actually affect this illness, this kidney disease? Is it, so genetics, is it inherited? Have I got it from my parents? Will I give it to any children I may have? And then support. What support is out there that is separate from my own hospital or my own kidney patient association in my own hospital? So how did the focus group compare to the sort of raw, unfiltered social media conversation? Well, only diagnosis and diet actually came up as themes that we found in the social media analysis. So disease progression, what the treatments did, genetics and support didn't. So what did come up in the social media analysis? Well, the one that was most frequent was about symptoms. So what am I going to feel? If I feel something, is that traceable to my IgA, or is it totally unrelated? That kind of thing. Diet was second. Diagnosis was third. And then treatment. But it wasn't necessarily, how does this help my IgA, or how... It was, am I feeling this because of the treatment? Or am I going to feel this because of the treatment? And then finally, it was about how the IgA was going to interact with any other illnesses that I might have. So Is it going to affect my diabetes, or has my diabetes caused it? That kind of thing. So I think by looking at this, what we really learn is, A, there is a huge unmet need for us as healthcare professionals to give people the information that they actually want and that they actually need to help them achieve their best health. But the only way you're going to be able to do that is if you do that in different ways. So focus group, kind of looking at social media, that kind of thing. And just a word on something. So something that comes up very frequently is people talking about pain in their kidneys. And a lot of people with IgA think that that's worse after they've had a viral infection, cough or a cold or something. This is a quote, anonymised. I've mentioned it in the past. They said kidneys don't cause pain and it must be muscular. I've said that hundreds of times in clinic, and I'm really sorry, right? But, you know, this is what I used to think. And now I think, well, actually, even if this is what I think as a consultant nephrologist, I need to get better about talking about this with my patients, and how am I going to be able to do that, and how am I going to be able to improve and check that I'm improving day by day in talking about symptoms with my patients. So where we're up to is we've looked at the social media and we've come up with these themes. We've called that phase 1. If you call something phase 1, there's always a phase 2, right? So what phase 2 is, what we're going to do is we're going to take these themes and we're going to create sort of more bespoke type educational resources for patients with IgA nephropathy about the themes that we've found that don't seem to be covered in existing educational resources. And then we're obviously going to use the internet and social media to put those out there. And then we can clearly go back and repeat the cycle and look at the social media data again to think about whether the things we've made seem to be reducing the need for people to have information about those areas. And we're very excited about getting started with that. So that's pretty much it. I think we all know that targeted social media data analysis is possible and powerful now after Brexit. But equally, what I think we're learning is use of social media is going to allow us as healthcare professionals to better respond to the needs of our patients and therefore help our patients to achieve their best health by themselves. So I'm a tiny irrelevant part of this. Most of the work is led by John in Leicester and Paula in Salford. Christina and Christian are also in Salford. Matt's in Leicester. Kidney Research UK gave us the moolah. And obviously, we're very grateful to the IgA Nephropathy Patient Focus Group. So I'll answer some questions if you want. Thank you.
Hello. You spoke about improving the educational resources that you've got through your analysis. Someone online would like to know where they can access the existing information and resources.
So often the best place to start is, I've taken my lanyard off, is the Kidney Care UK website for general things about CKD. I'm not sure, John, you probably would be better able to think about where the best place for IgA specific.
So part of doing this is that there hasn't been anywhere. If you go online, you will find lots and lots of different sites of very varying quality and accuracy. And the main reason the Facebook page was set up was because one of my patients sat with me in clinic and said, I'm just completely confused because I've read different things on different sites. So in terms of what we have in the UK, the Kidney Patients Association, Kidney Research UK is revamping its information, and Radar has a website, and the IgA Nephropathy information on there, which I think has been partly written by myself and Phil and Margaret, has information there as well. And those are the places I would go to begin with until we have the data, until we have the educational resources up from the work that we're doing.
Thank you. I was interested in what you said about the patient saying they've got pain in their kidneys, because this is very much a two-way process. I mean, it's great that you're thinking about getting information out there, but this is a really good way to get information in.
Absolutely.
And I think, as a kidney patient myself, some of the received knowledge in doctors, which is great, it doesn't recognise some of the effects of having kidney disease.
Yeah.
For example, I am constantly cold.
Yeah.
And if there were, not everybody feels that, but if there were enough patients feeding things like that back, you could at least say to patients, that's not uncommon.
Yeah.
Even if there's nothing you can do about it or need to do about it. So it would be really good in this study to look at how you can get those sort of non-clinical aspects of having kidney disease together, so we understand that few people do suffer other things.
Absolutely, I totally agree with you. It's great to hear you say that, because I think, you know, the slightly less common things, but that are genuine, once you've got enough of people saying it, as you say, we can all say, yeah, we've seen that, we know about that. Yeah.
So one of the things I just want to say is, Tom mentioned about kidney pain, and that is something that comes up a lot. And so Matt Graham-Brown will be submitting a grant to Kidney Research UK next year, where we are going to take that and run with it. And what we're going to be doing is asking patients, if they're prepared to travel to Leicester, that we will scan your kidneys. Because one of the ideas is perhaps you get pain because when you have a flare-up, the kidneys swell. And when they swell, they give you pain. So what we want to do is, because this is perceived as a big problem for patients, is we're going to scan kidneys with an MRI scan you when you've got pain, and then ask you to come back when all the pain's gone away. Then we can three-dimensionally reconstruct your kidneys and compare what they look like when you have pain and what they look like when you don't have pain. And the only reason we're doing that study, because this is not something that we normally do, is because what came out of this work was that was one of the key things that patients were complaining about the most and getting very short shrift from anyone they mentioned it to. And that's putting it mildly.
Hi there. I work for a multinational company, and one of the problems we've always had is trying to get all sources of data in one place so you can have a single source of truth. So you touched on the fact that the UK kidney site is bringing things together, but are you going to try and bring in other true sources into that database so that, you know, you build a bigger, maybe a global source of truth for everybody?
In terms of information about diseases, yeah, this is a very interesting topic in that, and I can talk for a long time about it, so stop me. But there's a website called NHS Choices, which was conceived as the kind of dictionary of illnesses that the NHS deals with, and was conceived as being the site that you could go through. That has not panned out at all. And I know people who have tried to get information about disease X or whatever onto NHS Choices and found it extremely difficult. So I think once you are going past kind of things that keep people out of GP surgeries and A&E departments like flu and things into more specific things, certainly in the UK, there is very little kind of logistical ability to put that in a central website. So I think the job of a lot, those of us who are on social media, or the job of things like Kidney Care UK and Kidney Research UK, is to put up their own resources or to act as signposts to useful resources. But in terms of a central repository type thing, I think that's a long way away, unfortunately.
So I just want to mention, the initial work we did with Twitter, we got someone to translate Twitter feeds from, I think, 10, 15 different countries, and it was very interesting. So in Japan, you may or may not know, the standard treatment for IgA nephropathy is to have your tonsils removed. So when we looked on the Twitter feeds from Japan on IgA nephropathy, and we translated it, it was full of 20-year-old people sat in hospital talking about what it was like having a tonsillectomy, which we never saw in any other country. So it is possible to try and take what we've done out of the UK, and we will find lots of very interesting things, but it does become an issue with language. But that is something that we've been thinking of doing.
Thanks so much. That's all.
Thank you.
Okay, next, I'm very pleased to introduce Dr. Kate Bramham. Kate is a consultant kidney specialist and researcher at King's College, runs a specialist renal pregnancy service at King's, and is deputy lead for a UK renal disease and pregnancy study group. So thanks so much. She's going to talk on IgA nephropathy and pregnancy.
Thank you very much for inviting me. Katherine Clark is my expert midwife who has suddenly disappeared, but hopefully she'll be joining us very soon because she's the person that has got a lot of the answers for some of the questions that you'll want to ask. Today I was going to really sort of give a quick overview of pregnancy for patients, particularly with kidney disease, but then we'll go on to talk a little bit about IgA nephropathy. And forgive me if there are people that this is less relevant to, and I won't be offended if you decide to have a little doze in this lovely warm room. That's moving, that's not. Apologies. That's my next slide. No worries, I'll keep on talking. One of my roles as a kidney specialist with an interest in pregnancy is really to sort of spread the word now. I think that pregnancy is possible for most women who have got kidney problems and most men. This really saddens me when I read this. This is a publication from, thankfully, a few decades ago, but it suggested that doctors should decide whether or not women have children. It says here, children of women with renal disease used to be born dangerously or not at all. Not at all if doctors had their way. Many women disobeyed their doctor's orders with happy results, and a few were less fortunate. But I think the key message is that the majority of women do have healthy pregnancies, but there's a lot of anxiety from healthcare professionals because it's something that they're uncomfortable with, it's something that they're unfamiliar with. And it's important, it's my job to educate the healthcare professionals, but also for you to understand that it's something that's very important in a lot of people's lives, having children, and it's something that should be possible. I use this slide because a lot of the midwives think that chronic means that it's a really severe problem, and I'm sure that you're all aware that chronic kidney disease, it sounds awful, doesn't it? And I wish that we just use the term kidney disease, but chronic doesn't mean that it's bad, it just means that it's kind of ongoing. We've had a lot of changes really over the last 2-3 decades in terms of how people can become pregnant, how we look after them during the pregnancy, and how we can support the kidneys during a pregnancy. So this decade is exciting, I think, in terms of having good outcomes. I'm not going to talk about how to get pregnant. I think it's a little bit early in the day for that, but I think it's an opportunity to really sort of discuss about male fertility here as well. I think really the general message is reassurance. There's no firm evidence that IgA affects fertility in any way, other than as kidney disease progresses, people find that they're less interested in having sex. People might find that it's harder for their partners to become pregnant. And my recommendation is that if you are thinking about a pregnancy and there's any delay, it's always worth getting advice early on because the clock ticks, and unfortunately we're not all able to get pregnant until we're 80. The time there is a window, and to seek advice early is always a very good idea. There is also some medication that can affect fertility in men, and that's something that needs to be discussed directly with your doctor. I'm not going to touch on this in great detail, it looks awfully complex, doesn't it? But just to really say that as kidney disease progresses, it can also affect fertility hormones. And so I always say to women, if you're thinking about having a pregnancy and your kidney function might be starting to decline, think about having that pregnancy sooner because it'll be easier to get pregnant and the pregnancy complications will be fewer. One thing that we've recently discovered is that previously we thought that women just, if they had dialysis, if they had end-stage renal failure, they just couldn't become pregnant. But it was very interesting in Canada, they increased the number of patients that had access to nocturnal hemodialysis. Don't ask me how they got pregnant on nocturnal hemodialysis, but anyway, they did. Of all the women who were of childbearing age, 1 in 5 became pregnant. And this was a little bit of a problem because they hadn't actually counselled women that their fertility would return with better dialysis. We have lots of discussions with our patients about if they've got advanced kidney disease, whether or not to think about having a pregnancy on dialysis. That's a complicated discussion, but it is possible, or to wait until the kidney transplant becomes available. As I've already alluded to, if you don't become pregnant fairly quickly, I really strongly recommend getting a formal assessment. And it's something that your GP can refer you to an assisted conception unit. It doesn't mean that you have to go through an IVF cycle, but it just means that you're not committed to that path in any way. But it just means if there are any treatable problems, they can be identified early, dealt with, and then you're able to kind of get on with the process. The other thing that's absolutely amazing is that assisted conception rates have been increasingly successful over the last decade. There are various different countries where assisted conception is unregulated, and we do have a lot of patients that come from abroad who've had egg donation or assisted conception, and perhaps in different ways than we would provide it in the UK. But it's definitely allowing the hurdle of fertility, reduced fertility with advanced kidney disease, to be overcome, and I think that's very exciting. One of the things that we do now recommend is that there's a test that we can do to look at how likely it is that somebody is going to become pregnant. And this is called the anti-Müllerian hormone. All women are born with a set number of eggs, and those eggs, the number of eggs starts to deteriorate as you get older. And this really gives you a bit of a steer as to how many eggs are left. And that can be very useful when you're trying to plan and decide when the best time would be to have a pregnancy. And certainly your anti-Müllerian hormone level becomes lower as you get older, and that's unsurprising. But it does start to become lower really sort of from the age of 30 onwards. So I don't want to alarm anyone in the room, and a lot of people do become pregnant later, but it's just something, again, to sort of think about pregnancy sooner. And we've looked at this hormone in women with kidney disease, and we found that it seems to be unaffected by the kidney function itself. That's to say that the test is definitely valid in women with kidney disease. One thing that we've also found, though, sorry, this is a rather complicated slide, is that luteinizing hormone, which is the hormone that is released when the egg is released, if that makes sense, it stimulates the egg to be released, and it's the hormone that's tested for in urine tests, so it tells you when you've ovulated and when would be a good time to try to conceive. It may be that this hormone is affected by kidney function. That is, that the concentration, the amount that gets into the urine to trigger a positive test to say that the ovulation has happened, may actually be reduced. So this test, the urine test to tell you when an egg has been released, is potentially less reliable as the kidney disease progresses. It may be that you are actually ovulating, but the test is negative. One thing that we do strongly recommend for women who've got kidney disease is that obviously natural conception of twins or triplets, well, that's good luck. But if you wouldn't choose if you were having assisted conception to have 2 embryos implanted, just because twins are challenging pregnancy-wise anyway, and to put the strain on the kidneys at the same time is a bit too much. One thing that we're commonly asked about is about the medications before planning a pregnancy. And lots of patients with kidney disease are on these medications. There's been a real shift in our way of thinking about this. And historically, as a medical student, I was told, oh, well, if a woman has got married, then she shouldn't be on any of these medications because she might become pregnant and this might affect the baby. We now fight, and these are general recommendations from different countries. This is the United States saying if a woman's having sex, then she shouldn't be taking these medications. Things are a bit more relaxed in the UK. But this was based on a suggestion that these medications were associated with abnormalities, so the baby's having problems with the hearts and potentially problems with the brains. I'm not going to go into this in a lot of detail, but now we're a lot more reassured that actually it's probably the conditions themselves or the things that are associated with the conditions themselves that mean you're taking the medication. So if your blood pressure is higher, that is the thing that's more likely to be causing these problems with the babies. It's not the ACE inhibitor itself. And actually, I really strongly believe that entering pregnancy in the best possible state, which means having good blood pressure control, having reduced protein in the urine, which these drugs do, is the best way. And so actually, I very often recommend that people increase their dose before they have a pregnancy and that they test regularly for pregnancy so they can stop it as soon as they know that they're pregnant. These can be bought very cheaply online these days, so you don't need to break the bank with the fancy ones. Okay, so moving on now to antenatal care, and this is one of the other changes that's really, I think, enhanced the outcomes for women with chronic kidney disease. Sadly, we like to look very carefully, and we like to look after our women very closely with chronic kidney disease. So lots of women can have a midwifery-led sort of non-medicalised pregnancy, but towards the end, we tend to look a little bit more closely, and it becomes a little bit more of an industrialised process. But a lot of women say that gives them a lot of reassurance to know that they're well and know that their baby's well. So at the moment, that we're continuing with this practice. Part of antenatal care, routine antenatal care, that we do tests to look to see whether or not the baby's got Down syndrome and other genetic problems. And one of the things that we found is that part of the testing is affected by having reduced kidney function. So a lot of women who've got kidney disease may have these false positive results. So they may be falsely told that they've got a high risk of having a baby with Down syndrome, which obviously is rather alarming. So it's really important that we do the calculations for the risk prediction without the factors that are affected by kidney disease. But also now we have the opportunity to do this additional test, which actually looks specifically for the baby's DNA in the mother's blood. So we can test and we can be 100% sure without additional tests putting needles into the baby, for example. So it's important to kind of be aware that if the kidney function is very reduced, then this might be an important additional test to have. We often need to change other medications before pregnancy, and there's a lot of conflicting advice between the midwives, between the obstetricians, between the GPs, and rather frustratingly and unsurprisingly, I suppose, there haven't been any trials done in pregnancy, and none of these medications are actually licensed to be used in pregnancy. So if you read anything in the package, it'll say do not use in pregnancy and discuss with your doctor, and often the doctor that you're discussing with doesn't know either. So it's really important to seek advice from someone who has experience, and a lot of kidney units now have a specialist service where you can go and talk if you're planning a pregnancy. There are various different medications that we don't like to use in pregnancy, but these are the ones that we use a lot of, and many women will recommend that they take aspirin during pregnancy. It doesn't affect the baby in terms of their development, but we think it reduces the risk of complications, including having small babies. Lots of blood pressure medications that we're very comfortable with, and some of these medications we may need to stop before pregnancy as well. MMF is one. I don't know if many people are taking that for their IgA. Rarely, I think, but that's one that we know can be very harmful for babies, so we make sure that that's stopped. What are we looking at the mother during the pregnancy? We look very closely at their blood pressure. The blood pressure can start to fall during the pregnancy and then rise towards the end. The challenge for us is to find out whether the blood pressure suggests that there's something worrying going on, like the placenta isn't working so well and it's releasing toxins and putting the blood pressure up. We now know that actually keeping the blood pressure low is pretty important for protecting the mother during the pregnancy. Previously, there was concerns that if we kept the blood pressure too low, then the baby wouldn't get enough blood flow and that the baby would be very small. We also look very closely. You're very used to this in your kidney clinic. It's just the same. It's blood pressure and it's urine dip. But we look very closely at the protein in the urine, and that naturally goes up because the kidneys are working so much harder in a pregnancy. This is a patient that we've recently looked after who had IgA nephropathy, and her protein leak in the urine went up massively during the pregnancy, and everybody was very worried about her having preeclampsia, but in actual fact she didn't. It was just the kidneys just coping with the pregnancy. Sometimes if the protein leak gets very high, we worry that potentially the blood becomes stickier and that we may need to give injections just to keep the blood a bit thinner and also to ensure that the placenta is getting good blood flow as well. We track the kidney function fairly carefully, and it's one of the amazing conditions that actually improves kidney function. And if everybody with chronic kidney disease could become pregnant, then we'd have a solution, believe me. One of the other problems that we see, and it isn't a problem, but we do identify that the kidneys actually become bigger and swollen in pregnancy, and they actually look on ultrasound that they look like they might be a bit blocked. And that happens in about 80% of pregnancies. So that's a normal finding, and people can get very worried if they're not familiar with it, but actually that suggests that everything's working okay. Now, one of the major concerns and why lots of kidney doctors are worried about pregnancy is that, as I said, the kidneys have to work harder in a pregnancy and it can put strain on the kidneys. And historically, there are lots of negative outcomes reported. This is some data that we've recently pulled together, and forgive me, it looks a bit complicated, but we've looked at women who've got more advanced chronic kidney disease. And generally, the gist is that, yes, the kidney function can get worse as a result of pregnancy, but it's by no means in everybody. And if we're looking at everybody overall, it's approximately about 1 in 3 women who've got advanced kidney disease, but particularly those with very advanced kidney disease. So we're looking at women who've got sort of kidney disease with function less than 30% that are going to have problems, and the kidneys might deteriorate during the pregnancy. And I think my concern is that this message basically is sort of broad brushed over everybody. If you've got kidney disease, then you're going to have a bad pregnancy and your kidneys are going to fail. And that's just simply not true. It's a minority for that to happen to, and those women still can also have a pregnancy, but they need to understand what the future might hold as well. This is looking specifically at women who've got IgA nephropathy, and most studies are actually everybody altogether. And I have to say, I like looking after women with IgA nephropathy because they do really, really well. They seem to have reduced complications compared with the other women who've got kidney problems. And these are studies that have compared women who have had pregnancies with IgA nephropathy and women who haven't had pregnancies. And generally the message is that overall, it doesn't cause a progression in the kidney disease. This is looking at the complication rates of women who've got IgA nephropathy, and generally, unsurprisingly, that there are slightly higher rates of some complications. But if you look at what that means in real numbers, in normal pregnancy, women have a 1 in 20 chance of getting something called preeclampsia, which is when the blood pressure goes up and the protein appears in the urine. But actually, overall, these women with IgA pregnancies, it's double, yes, but overall it's only 1 in 10, and that's something that we look for very closely. We monitor the baby very closely to see whether or not they're getting sick, and we can deliver the baby when we're concerned about that at all. I'll just skip on that. And the obstetricians are incredible these days. I often sort of deflect to them to say, well, when should we deliver this lady? She looks fine from my perspective. What do you think? What's happening with that baby? And then they can look at how the baby's coping with the pregnancy. They can look to see whether or not the baby's oxygen levels are getting low. And if the placenta is not working so well, and it's not feeding the baby, we can see that the baby is starting to change the pattern of its blood flow. It's starting to increase the blood flow to its brain, which means it's preserving these vital organs. And that we know over a period of time, if we leave that baby inside for too long, that baby's not going to survive. So it's really, really essential that we've got an obstetrician that's tracking the baby's well-being as well, and that can help us decide when to deliver. And one of the challenges that we have is getting the timing of the delivery right, because if a baby's born too early, then potentially they could have much more complications. And that's why we're kind of saying, oh, let's just go on for a bit longer, because babies are more likely to die. This is a group of babies that were born before 34 weeks. And you can see the grey bars here, the number of babies that died. Obviously, 26 weeks, a lot of the babies died. That's actually getting a lot better, even sort of year by year. The babies that have long-term problems, these are the ones in red that survive but have long-term problems, reduce obviously as time goes by. But I think that we tend to paint a very bleak picture, but actually overall look at the green. These are healthy babies that survive, that do really well, that go to school. So I think that we need to take our mind off all the problems. We need to be aware of them, but we need to really be positive as well. And if we think about what the neonatologists can do now, it is extraordinary. Every time I hear a neonatologist speak, I'm kind of in awe. They have so many advances in terms of their ways to protect babies. This is when neonatology basically first started, and it was funded by people paying to go to have a look at these little creatures in the incubators, and they used to walk past, and probably a lot of them didn't survive. But this is a really premature baby that's been born. It's supported on practically every organ is being supported, and it's being able to be held by its mother. And that is absolutely incredible if you think that that's being able to that is being delivered throughout the UK now. This is the next bit, which I need help from Katherine, because I don't do this. Yes, I hand over to the experts at this point. Okay.
So like Kate said, we tend to treat people with kidney problems exactly the same from a midwifery perspective, and our aim is to keep everything nice and normal. So what we want to happen and what we aim for in every pregnancy is that we wait until labour happens spontaneously, and hopefully that's around your due date. But it's a balance, and we have to think about all those things we're monitoring antenatally to see whether plan A, waiting till your due date, is most appropriate, or whether actually something's changed and suggests that we need to help the baby come sooner, whether that's by us inducing labour, so using drugs to help labour start sooner, or whether a caesarean section is indicated for whatever reason. These are the sorts of things we'll be thinking about to help us make that decision. And one of the things that we can get really caught up on as midwives and obstetricians is whether it is preeclampsia, this condition that Kate touched on. But actually, a take-home message for any of the clinicians in here is it doesn't matter. If these things are changing such that we're worried about you, then the plan should be to keep you and your baby safe. And if these things are changing, that's by delivering the baby. Yeah? So this is just thinking about how is best to deliver the baby. And we do actually know that in people with kidney problems, you are at a higher rate of reaching the point where an induction of labour or indeed a caesarean section is recommended. So you can see the average here, with or without preeclampsia, it's sort of 40 to 50% in people with kidney disease compared to 5% for induction rates in the normal population. And for a caesarean section, it's the same. It's significantly elevated in people with kidney disease. And I think that's partly reflective of the fear that Kate was mentioning, and so I think these figures are probably actually better now. I think we're less keen to deliver babies ahead of the spontaneous plan. But then the thing to think about is, how do we decide? How are we going to choose whether birth in the old school way, the natural way, trusting our bodies, letting our bodies do its thing, the benefits of a natural birth outweigh the benefits of a caesarean section, so an operative birth. And there's lots of positive things about a vaginal birth. We're designed to do it. Yes, it can be sore, but there's lots of good things. We avoid infection rates, you get home from hospital quicker, you're less likely to need a caesarean section in a future birth. And with any caesarean section, even in someone who's perfectly healthy, there are significant risks associated with it. Again, we're good at them, I say we. The obstetricians are very good at caesarean sections. So as operations go, they're relatively safe. But it is an operation, so we always try and promote labour over a caesarean section. And that's true for people with kidney disease. And when I talk about induction, what do I mean? Well, it's quite a long process, and you might well have heard people talk about the 4, 5, 6 day labour that they've had. And society is quite good at emphasising the challenges of birth. And when we're inducing labour, so when we've made a decision that we need to help babies come sooner, we try and mimic the natural process of labour, which is timely. It does take time, so it's quite a slow process. We can offer you ahead of that something called a sweep. Some of you might not know who this is, but part of my childhood. And sweeps are a way of trying to naturally encourage labour to start. So it's a vaginal examination. We try and stimulate some of the hormones that can help labour start. And that's helpful in normal pregnancy towards the end, and also in preparation for an induction. We will always monitor the baby carefully, and that's even more important if we're stimulating labour ahead of your due date. But actually, if we were worried about your blood pressure, or if we were worried about how much protein leak you had, then we'd be monitoring the baby continuously and very carefully throughout labour and pregnancy and labour. So one thing that people do get caught up in is whether all the pain relief options are open to people with kidney disease. And I can absolutely say that everything is safe. You can absolutely use any of the pain relief options that are usually used in labour. We do just need to be a bit cautious with opiates, but that's something that you would have an individualised conversation with your nephrologist about. And we would recommend most people to see an obstetric anaesthetist in preparation for their birth, so those conversations could be had. So what would make that balance tip? When would we be recommending a caesarean section over an induction? And it would be normally if we were worried about the baby. So if on those scans that Kate was mentioning, we saw a change such that we thought the placenta wasn't working quite so well, then we would recommend considering an induction, because the baby's likely to have used up lots of its reserves that it needs to tolerate labour, tolerate contractions. And with any induction, especially when there's placental insufficiency, so especially when we're seeing signs that the placenta is not working so well, there is a risk of needing a caesarean section in labour, and that goes up when you've got this placental insufficiency. And the risk of that goes up 24%. I didn't know I had the number there. So the risk is 24%. Good. So talking about the total vaginal birth over total caesarean section, actually, it is higher than the national caesarean section rate for women with kidney disease, but not significantly. So I think it's about being reassured that we will do our best to facilitate the birth choices that you make, and your risk of a caesarean section would be a little bit higher, but not dramatically. So then you meet your baby, which is what the game is about. Kate's mentioned that there is a slightly higher rate of women with kidney disease as babies going to the neonatal unit. That's actually my daughter's feat, and I can promise you that it's not as scary as it sometimes sounds. They, as Kate said, the neonatologists are just phenomenal. For everyone with kidney disease, whether your baby's been in the neonatal unit or not, for you to look after you, we'd need to ask you to stay in the postnatal ward, or we'd recommend staying in the postnatal ward for at least 48 hours, just to make sure that your kidneys are tolerating the blood loss that you've had after birth and the fluid shifts that happen around that time. So a slightly protected stay in the postnatal ward is what we'd recommend. And then we want the follow-up to continue once you go home. And that follow-up is with a number of people. Sorry. Well, pass on from that. That follow-up's with a number of people. So it's with midwives, with health visitors, with your GP, and communication with your nephrologist as well. Breastfeeding is recommended for all internationally. It's definitely what the WHO, the World Health Organization, recommend, and there's a whole long list of reasons why that's good for you and your baby. The thing for people with kidney disease to think about is that actually, if you imagine you're producing milk, that uses a lot of your water. So you need to make sure that you're drinking appropriately for the amount of milk you're producing. And that's, again, something to talk about with your midwife or your obstetrician and nephrologist. What we would recommend is considering expressing some milk antenatally, which is something to talk to your midwives about, especially if there's a likelihood of your baby going to the neonatal unit, because then you can help ensure that the babies are getting colostrum, getting the awesome breast milk, even when they're not able to feed directly from you. And drug safety, this is something that we're still not good at. And midwives and obstetricians are very good at telling you can't take your medicines while you're breastfeeding. But actually, from the tablet sat on your side all the way around to it getting into the baby's bloodstream, it's got a long way to go. And so often, for the majority of drugs, it's perfectly safe to carry on while you're breastfeeding. These drugs are absolutely safe. Even prednisolone, which has a small amount in the breast milk, it's still considered to be a safe medicine in pregnancy. The only one to stop is the same MMF, but you wouldn't have been taking that in your pregnancy anyway, so that's quite easy to remember. All the antihypertensive drugs listed here are safe, and again, the majority of the drugs that you'll be on would be fine, and they'd have been changed antenatally. So the drugs that are safe in pregnancy are also safe for breastfeeding. So your follow-up care, I've touched on this, will be a team effort. Your health visitor, your community midwife, your GP, and the focus at this point often shifts onto the baby, but actually it's really important that we remember to look after you too. And let us, really do let us look after you. And we will do our best to communicate with everybody, including you, to make sure you've got the appropriate follow-up. One thing to say is proteinuria. If anyone suggests checking your proteinuria in the postnatal period, you bleed after you have a baby. There is protein in the blood, and so it's totally not useful test to be doing in the early postpartum period, because you're going to be quantifying the bleeding too. And just a final point, that for some women who've had a perfectly uneventful pregnancy, their kidney disease has stayed in control through their pregnancy, it can deteriorate. So you see 23% have a deterioration post-delivery. Their first change in kidney function is post-delivery, but before 6 weeks, and 10% it's actually after 6 weeks postnatal, but before 6 months. So it's really important that you keep up with your regular monitoring postnatally. So what can you expect from us? It's individualized care. It's shared decision-making, coordinated care, and communication. And we will treat you like we would treat anyone else. So this is just a summary of what we've talked about. Pregnancy is totally possible for most women. Fertility treatments are worth considering and might increase your ability to become pregnant particularly with severe disease. We recommend aspirin for everybody with kidney disease planning a pregnancy. Close monitoring is super important, and our aim is to treat you like everyone else and for you to have a healthy baby at the end of it. Thank you very much. Any questions?
So if anybody's got a question.
Right, you mentioned about taking aspirin. Obviously, taking aspirin during the pregnancy. Would you recommend taking aspirin whilst you're trying to conceive as well?
So at the moment, thank you, good question. At the moment, the recommendation is to start aspirin from about 10 to 12 weeks of pregnancy and continue it right till 36 weeks of pregnancy. Some people get worried that aspirin can increase your risk of a miscarriage or can increase your risk of bleeding. Actually, we have no evidence for that. Aspirin is safe in pregnancy. It's a small dose we recommend, just 75 milligrams. So if you buy it from the shops, it's baby aspirin, it's often referred to, and it's perfectly safe. And if you have bleeding, we recommend to stop it, but it certainly won't cause any bleeding. So from about 10 to 12 weeks is the recommendation. Yeah.
I just wondered how treatment, particularly in the event of a cesarean being needed, was different for a transplanted woman.
So what we would do for someone who had a transplant is we would make sure you had your cesarean section at a place where there was a transplant team, so that one of the transplant surgeons could be present for the cesarean section. That's certainly the practice in our hospital. And that's not because we expect there to be any problems, but it's just a pair of eyes who are very used to looking at transplanted kidneys to help us make sure that we're not going where we shouldn't be. It's something that was planned. It would be multidisciplinary, so the transplant team would be aware that we were planning the cesarean section, and there would be a plan put in place irrespective of the planned mode of delivery. So even if you were hoping for a normal birth, we'd put that plan B in place and make sure everyone knew that you were in labour. Yeah.
Can IgA be passed on to your children?
Pass it.
I think that might be covered in a talk this afternoon on genetics, so we'll leave it for that.
Thank you.
Yes, yeah. Okay, I think that's it. So thank you very much again. So very lastly, a very short talk, I think 10 minutes. I'm very pleased to introduce Sarah Harwood from Kidney Research UK. Sarah's a kidney patient. She's had a kidney transplant for about 11 years now for anti-GBM disease, and now works as a patient involvement coordinator at Kidney Research UK. I'll just wait for her to get her microphone on. And then there'll be lunch after this. Okay.
Hi, so yes, I'm Sarah. I had a kidney transplant when I was 19 years old. I went into end-stage renal failure when I was 18, and I actually had a very different disease to all of you guys. So it was a glomerulonephritis, so it's similar in that sense, but mine was very aggressive. So I went from perfectly normal functioning kidneys to within about 4 months. If my parents hadn't taken me into hospital that week, I'd have died from kidney failure. So what I'm talking about today, though, is Kidney Research UK. So this is, you've heard us mentioned a few times today, which is fantastic. So we are the main funders of research into kidney disease in the UK. And what we do is to fund and deliver life-saving research into kidney disease. But we also want to increase awareness of kidney health, improving treatments, but also get patients more involved in what we're doing, what we're talking about, and making sure that what we're funding is what patients want us to be funding. So that is what I do. So I'm the Patient Involvement Officer at Kidney Research UK. So I've been there now for about 4 years, and my role is to engage with patients and empower you to get more involved in research. So this is the way that we try to talk about what the sort of research, what the kidney problem is, and there are some really terrifying stats on there. The one that's always scared me is that a person on dialysis aged 25 has the same cardiac prognosis as a 75-year-old. So as someone who was on dialysis when I was 18, that to me is terrifying. I had no idea the impact that these treatments could be having. And some of the other stats on there, you can see 60,000 premature deaths in each year in people with CKD. These are quite big numbers, it's quite terrifying, but what I've seen over the last 4 years working at Kidney Research UK is the difference that we are making and the difference that the researchers you've heard from today are making. It's incredible to be able to see how research is actually changing patients' lives. And what I would really want you to take away from me talking today is to look at research, see how you can get involved and see what the different ways you can engage with research are. So what is patient involvement in research and why is it important? So it's about an active partnership between patients and researchers. It's not about us sitting there as guinea pigs having things injected or things taken from us or whatever it is. It's about us really engaging with it. It's really important that we're participating in clinical trials and like John was talking about earlier, giving our blood, giving urine samples and things like that, because that research can't happen without our participation. But it's more than that as well. It's about advising on that research, making sure research is focused on what patients are needing, and that the design of research projects are designed with the idea of patients are people who have jobs, have families, have lives, and how can we make sure that that research is working around that as well. But it's all about patients getting involved and helping research be better. So this is some of the different ways that patient involvement in research is really helping. For researchers, it actually can help them get funding. So for a lot of funding bodies now, you can't actually get your funding unless you've got some element of patient involvement in your work, which is great because it's forcing researchers to have to talk to us. But it's also really important in making that research better, in making sure that the questions are more relevant. And there's a huge amount that researchers actually get out of involving with patients, engaging with patients, and talking to them about understanding the experience of living with kidney disease. And this is Kate Paget is one of the patients on the renal imaging network that we support, and she has been really involved in attending meetings and using her experience and understanding of kidney disease and relaying that to the researchers and everybody else in those meetings. She's helped writing supporting letters for funding applications. She's speaking at meetings. She's helping review documents. Developing patient information should be developed with patients because they're the ones that you're talking to. So she's found it amazing being involved with research, and it's really helped her to understand her disease even more and understand and interact with patients and researchers in different ways. And one of the big things I want to talk to you about today is Kidney Voices for Research. So we've recently launched a online network or community of patients who are interested in being involved in research. It's about sharing and understanding your experiences of being involved in research, but it's about hearing updates on research and hearing opportunities of getting involved. And it's for researchers to utilise to connect with patients even more. How many people in this room are on the Kidney Voices group? Fabulous. I know there are some. Excellent. Well, excellent there are some, but they're also excellent in that I've now got a whole big group of people who I can get to join. So we've only just launched this in the summer, and we're really building on it and trying to get it to grow. Hopefully lots of you will have had leaflets on your chairs for it. It's a simple online form just to make sure we've got the right consents and everything for contacting you, and there's a closed Facebook group that you can join to hear about opportunities and updates on research. this day, the IgA Nephropathy Patient Information Day, was advertised on there to encourage people to come along to it as well. And we try to link with as much as possible other people that what they're doing. So we just shared about the Leicester exercise team who are trying to get patients to go along to a patient involvement session that they're running. But it's all about research involving patients, and it's through Kidney Voices we're hoping that we can build that relationship between the patients and the researchers even more. So like I said, there's a closed Facebook group for it that you can join, but you do need to register with us through our website first as well. I do have some application forms with me, so if anyone wants one, they can come grab it from me. But the other thing I want to talk about is how important it is for us to hear from patients. I went to a young adult away day, and these were the kind of things when I asked them, what does research mean to you? And this is 18 to 30-year-olds, and I asked them, what does research mean to you? And the fact that we're finding out that it's about hope for the future, it's a better future, it's changing lives. This is all really important for us to be able to relay that back, to make that connection for researchers between the disease and the human beings behind it. And it's inspirational as well for the people who work at Kidney Research UK to understand what a difference research can make to patients' lives. And it's all about sharing and understanding the patient experience, I think, is what is really important. So we do a lot of work with sharing patient stories as well. So we've got little Daniel there, bless him, with his peritoneal tubes in. He's actually had a transplant now, December last year. He's doing really well. He's been in and out of hospital, but his mum Louise is looking after him really well, and he's an absolute delight. He's gorgeous. And big Daniel here, who was on our lay advisory committee. He joined when he was in his early 20s, and he just flourished and grew so much in his role, and coming forward and talking about his story and using his experience. He's now on the Regenerative Medicines Network doing amazing work with stem cell research and talking to researchers about how the patient experience can help and in that research area. So it's all about this, bringing hope to future generations and making research better. So hopefully that will have inspired you to get involved with us and to hear more about research and what we're doing, and join Kidney Voices for research. Thank you.
That's really fantastic. Thank you, Sarah. And I think lunch is ready. So if anybody has questions for Sarah, if they could catch her during lunch, would that be okay?
Fabulous.
And we'll just move to that. Thanks. So if everybody could come back at about 1:30, that'd be great to start the afternoon.